And as you know, next Thursday, 1 week from today, we will be immersed in our final exam. The final is going to be similar to all the other final exams you've had with me through the year. Since midterm, the questions will be equally distributed between the classes we've had, with extra focus, double focus on this week's lecture. I will schedule a review as soon as I've narrowed down the final exam piece. There's no point in reviewing until we know where we're going, if you know what I mean. And so there should not be any surprises from a final exam perspective. And you know where to find me in advance for any questions. Now, ATI, the proctored ATI comprehensive exam, I am going to offer it 3 different times. You're only going to take it once, but I'm trying to be flexible. And so the options are Thursday after the final. And then I believe I said, what did I say on the update? Saturday and or Sunday.
Yeah.
Okay. Again, you're only taking it once, but I'm trying to be flexible. It's a long exam, and the reason I'm not forcing everybody into Thursday is because it's a long exam. It's 180 questions. So I want people to be prepared. I want them to be fresh, and I don't want you either overly focused on that versus the final, or just the final and not prepared for the comprehensive. Because as I've said consistently, your score on the comprehensive exam, the proctored comprehensive exam, is going to tell us a lot about your plan for preparation for NCLEX. So while it may not count in a bunch of points in your 45, 54 grade in terms of your future, your next couple of months, it tells a lot. That's really where it becomes important.
Carolyn.
Yes.
Because you're offering a few different times to take the exam, do we have to sign up for a specific one?
No.
Or can we just take it whenever?
Show up, but show up at the beginning of the time. Don't, and I'm just throwing out numbers here because I don't have it in front of me, but if I scheduled 9 a.m., don't be strolling in at 10:30.
Yeah.
I probably won't let you in. I need everybody to sort of finish about the same time. I don't mind, I'm going to be egocentric and narcissistic about it. I don't mind, I've committed to the 3 times, no problem. But if I started it at 9, I did that with the vague expectation that I was going to be done around noontime. You come in around 11 and now I'm to 2 o'clock. And I'm not sure, I think you'll all see that that's not really being narcissistic. It's just applying a smidge of structure.
No, that's fair. Yeah, thank you.
No problem.
The way this is structured, we can pick any of those 3 days, or you're going to tell us which day we're taking?
No, your choice.
Okay, thank you.
Yep, your choice. But, yep. And if for some odd reason none of those 3 times work, let me know. We'll figure something out. I'd be surprised, like, short of you died, but I wouldn't wish that on anybody, right? Hey, do you guys, you probably don't, because you know me and my stories, I tell so many, but at the beginning of the year, I usually, and I know I told you this story about a student who was on his OB rotation, and there are a couple of stories I tell about what a difference a student nurse can make in terms of patient care and patient outcomes, because a lot of times students think they're just an add-on or an afterthought or a burden to the system, but I've got very real experiences. And I told a story about a student who was on his OB rotation, and he noticed something funky on the fetal heart monitor, and he figured everybody would come running because he thought it looked bad from what he vaguely remembered. And nobody came in, and he thought about using the call light, and he goes, well, no, I'll just get somebody. He looked out, and there's nobody in the hallways. He goes down to the nurse's station. It's freaking empty. He's looking around. He can't find his other students. He can't find the unit secretary. There's no one. He's thinking he and this patient are like the last two people in the freaking hospital. And he's running around. The unit was having some construction. So he finally runs around the corner, down the hall, around the corner again to where their staff room was. And he tells them, and he thinks they're having D cells, and everybody sort of rolls their eyes at this student. And finally somebody comes and looks, and sure enough, the woman was whisked off for an emergency C-section. And he had this poor guy. So basically he's got as much trauma about OB and having babies as I do. And his wife just delivered their second baby last week. And sure enough, he's of course staring at the fetal monitor and starts seeing D cells, and he thinks he's having this wicked bad deja vu, and he shakes his head and looks again, and sure enough, she ended up having an emergency C-section. And he goes, I swear to God, I knew that thing was going to come back to haunt me. But he felt, he goes, luckily people came running in, unlike my clinical experience where nobody but me seemed to care. He said the first time the alarm went off, everybody came running, but he said he almost died. Isn't that so? Good news, he remembered something from his OB rotation. Good news, mom and baby are doing well. And good news, you do learn something throughout your year here, if you aren't already sure of that. All right, so any questions, any concerns, anybody want to tell anything that's been going on in clinical that they've learned? Okay, I'm just going to take that as let's just keep moving, Carol Ann, for the love of God. All right, I'm hoping you see cancer overview at this point. And if you're not, you let me know. All right, so these statistics are somewhat interested in that it's estimating the frequency of different types of cancers. And men versus women are seeing different diagnoses. At the top of the list for women is breast cancer. The top of the list for men is prostate. Then it becomes somewhat more similar, except with a lot more lady parts being subjected to cancer than some of the other male parts. But it's fair to say that cancer is going to touch everybody's life in some way or fashion, and whether it's by diagnosis or care for a patient, it is a remarkably common diagnosis. And when we look at where the estimated deaths are, it's pretty clear that lung cancer is still the leading cause of death, despite its not being the #1 instance. It's only #2. But I think there are many research scientists out there who see that as a challenge to keep on looking for ways to mitigate that diagnosis, for sure. The word cancer itself is not particularly specific. It's actually a lay term. It means a malignant disease. And so professionals use it as well, but the actual, once you say somebody has cancer, to an oncologist or someone working with oncology patients, that just opens up a can of worms in terms of the information they need to know, because cancer itself just means the individual has a malignant disease. There's so much more specifics you need to know. And what's the difference between a healthy cell and a cancer cell? It's that cancer cells have lost growth, the typical, the normal, if you will, growth regulation of normal cells. They grow in abnormal ways. They proliferate, usually faster than regular cells. And this is very much at the expense of the host. They mutate, as it says here, they're genetically unstable, chromosomes are changing, and that is one of the biggest, it's both a challenge as well as the path to the promised land, if you will, in terms of treating and mitigating cancer. The more we find out about a cancer's chromosomes, the more success they have in mitigating the disease. So again, there's that loss of normal cell regulation. The other issue is the cells stop differentiating. They proliferate at usually a significantly higher rate, and they don't differentiate the way normal cells do. And they start growing and invading other tissues around them. And then to make matters worse, they metastasize, which means these abnormal cells travel to other areas of the body, implant and start the whole process. They invade other areas, if you will. And that's what metastasize means, to invade other areas and try to take over there as well. Again, now it is possible to have a benign tumor. It typically is different, obviously, than a malignant tumor. And how is it different? Well, the benign tumor pretty much looks like the surrounding tissue. It tends to grow slower. It's not typically fatal when it's treated, and it is it's much less damaging and causes less destruction to surrounding tissues for the most part. And the tumor, so long as it's either surgically accessible or via some other method of treatment like radiation and laser and things, it's rarely fatal. Again, malignant tumors, it looks different than surrounding tissues. And yes, it can be slow growing, but I think we see more rapid growth of malignant tissues. It is more typically fatal when not treated. It's able to metastasize. It causes damage to the surrounding tissues where it's growing. Again, it causes, if left unchecked and untreated, it causes serious damage with ulcerations and necrosis, and it often recurs. And that's another bit of a hallmark that's different between a benign and a malignant tumor. And of course, it's more often fatal, even with treatment in some cases. What starts cancer? How does this happen? And certainly there are still some questions that are out there, but there is typically some sort of initiation phase. whether it's chemical, radiation, or virus, something is impacting a normal cell and causing a genetic change in there. And this one cell changes and then starts growing in ways that are unexpected. Again, another more genetic changes as it goes. It becomes a malignant tumor. And at some point, it's going to be diagnosable, whether it's a change in function, change in size, whatever it is. But in this slide, focus on the initiation and what might cause that initiation. And so these are all those risk factors that we often talk about. Can anybody think about some of the risk factors that can lead to cancer?
Smoking.
Smoking.
Genetic disposition, I guess.
What was that, Jamila?
Like genetics?
Some genetics, but again, there's usually something that kicks it into high gear. Smoking was a great one. When we talk about radiation, we're talking, think sunlight, and its impact on skin cancers. Viruses, again, this, I've said before, oncology is not my bag, but I know enough about cats that we know that there's a cat leukemia that's relatively common that is viral based. Might not be a human model, but that's all I can come up with at this moment in time. And again, so metastasis is where these cells travel to other areas. And so you might ask, how does this happen? And so the most common ways are during surgery. They're very careful if they're removing tissue or tumors or getting biopsies to not seed surrounding areas. You really don't want to leave cells behind that will continue to proliferate and grow. The lymphatic system. We talk a lot about the lymph system and how lymph travels through the body in a similar way to blood. Well, that is a very common way for cancer to spread. This is why when they do a biopsy of a tumor, they also biopsy surrounding lymph nodes, looking for signs that the cancer has spread into the lymph nodes, which puts it at risk for spreading even farther and wider. And it can spread through the bloodstream as well. Different cancers have a different propensity for metastasizing in different areas, but it's often the sites of metastasis are very common: the bone, lungs, liver, and the central nervous system. So knowing, when we think about what those signs and symptoms might be, well, certainly in the brain, headaches, seizures, vertigo, palpating the lymph nodes, looking for lymphadenopathy. In the respiratory system, usually a dry cough, hemoptysis over time, shortness of breath. Liver hepatomegalia, looking for the edge of that liver as dysfunction increases, jaundice, and then skeletal pain and fractures. And that was, in my own family, this boy, again, I don't know why so many of my stories don't show me in my best light. And I probably told this story before, but we knew my father wasn't well. He didn't look good. He didn't feel well. He had been having tests all summer. I cannot fault the workup. Everything was done correctly. And he just didn't look good and nothing was coming up. And the Wednesday before Labor Day, my mother calls me. She goes, your father's in agony. He can't get out of bed. It hurts too bad. So I said, well, you tell him he goes to the doctor today or tomorrow, but we're not going to an ED on a holiday weekend. I know everybody in every ED in this county and the surrounding counties. And we're not going to go in and say, listen, I haven't been feeling well for 3 months, so I decided to show up on a holiday weekend. And he didn't, and he basically chewed my mother's OxyContins for a weekend. Tuesday, he goes to the doctor to do a couple x-rays, and he actually had a pathologic fracture of his hip. And pathologic means it's not traumatic. It was actually caused by a tumor that had grown so large it had fractured his hip and his pelvis. Immediately admitted, they did a biopsy, and it was also equally clear that that was metastatic disease. The hip, the bone, was not the primary site of the cancer. So then the next quest was looking for the primary site. But it was in fact this metastasis to the bone, which finally got a diagnosis of what was sort of going on and why he hadn't been feeling well. And the evil bitch daughter who told him either go to the doctor in the next 2 days or just suffer for 4. Yeah, okay. So again, carcinogens, these are those things that are causing cells to change, radiation, UV rays, different viruses, hepatitis. Oh, why didn't I come up with hepatitis when I was thinking about causes of cancer? We learned about that in terms of causing liver cancer, Epstein-Barr, HPV for women, and cervical cancer, sure. Asbestos, tobacco, alcohol, benzene. Working in laboratories and coming in contact with many of those chemicals can be pretty dangerous work. So there are many different carcinogens that are both known and unknown at this stage of the game. And really what cancer is a failure of the immune system. And so either the cancer overwhelms the immune system and the immune system's not able to destroy those cancer cells as necessary, or the immune system doesn't recognize them as different problems. They talk a lot about tumor-associated antigens. We know antigens are what help the immune system recognize good cells and bad cells, if you will. I don't necessarily, probably shouldn't characterize them as that, but those antigens help the immune system determine, is this part of our tribe or is this from outside? And so it becomes, the cancer cells get more and more creative in terms of how to dupe, if you will, the immune system. So the lymphocytes are usually the cells that are out there looking at the surface antigens, trying to identify abnormal cells. This is where our T cells, macrophages, B cells become important. They are called into action when the lymphocytes recognize that there are abnormal cells. And for some reason, again, these different antigens are not recognized as abnormal. And whether it's a cancer cell secreting something that suppresses the immune response, whether there's other cells being developed that again suppress the T cells, but the cancer cells are able to grow and reproduce unchecked, if you will. When we talk about primary protection, primary prevention, I should say, is about preventing the disease itself. So don't smoke, don't start smoking. Sun protection, they had Australia, which is primarily a very sunny place with temperate weather around throughout the year, if you will. They started a slop, slip, slap campaign, public health, which is a slop-on sunscreen of at least 15 SPF or higher, slip on your sunnies, as they call sunglasses, and slap on a hat to protect from sun exposure. And they had a remarkable decrease in the incidence of skin cancer, melanoma in particular. Limit alcohol intake, healthy diet, safe sex, engage in physical activity. So these behaviors, lifestyle behaviors, will actually prevent cancer. Secondary prevention is about early detection. This is why women should be having breast exams and mammographies starting at an appropriate time. Pap smears, prostate exams for men, have PSA testing, testicular self-exam. I know 3 gentlemen who were diagnosed with testicular cancer in their early 20s because of testicular self-exam. At least they called it testicular self-exam. But the bottom line is they identified a lump, they went to the doctor, and thank goodness they did. And then colonoscopies. Again, the age to start is supposedly 50. If you come from a high-risk genetic pool, like my family, you may start earlier than that. And again, women with higher incidence of breast cancer and other gynecological cancers may start all of these screening tests much earlier. The earlier a cancer is identified, the better the outcomes and survival rates. What are the warning signs of cancer? We use the acronym CAUTION: change in bowel or bladder habits, a sore that does not heal, unusual bleeding or discharge, thickening or a lump in the breast of other tissues, indigestion or difficulty swallowing, obvious change in a mole or a wart, and a nagging cough or hoarseness. Now, again, those are not the only signs, but we like our acronyms. They make it somewhat easier to remember some of these signs and symptoms. This is another, this indigestion, difficulty in swallowing. This is why it's important to actually take, whether you call it indigestion or GERD, seriously. Prolonged, untreated GERD can lead to Barrett's esophagus, which can lead to esophageal cancer. Another example of how early intervention and monitoring can make a difference. If you're looking for a diagnosis, usually that involves an oncologist or hematologist and or a surgeon. Obviously depends on what needs to be done, what type of cancer. So the surgeon is going to do the surgical removals of any tissue. Although, as we know, more and more biopsies are being done in interventional radiology, but oftentimes the resection of tumors is done by a surgeon. Hematologist is going to work with your blood-based lymph cancers, and an oncologist typically takes care of solid tumors and the management of chemotherapy. And then your radiation oncologist You want to talk smart freaking people? These are people who did really well in physics throughout their academic careers. They do numbers like the best bookie at the busiest track in town. They are smart people because they are constantly redoing calculations in their mind. So I should add radiation oncologists there also, because oftentimes you need to do either preliminary work on a tumor or post-surgical work on a tumor area. In terms of diagnosis, again, getting a very careful physical exam and a very careful history. Lots of blood work. They'll start with ultrasounds, CAT scans, and then once they're pretty sure of a diagnosis, the PET scan becomes a bit of the gold standard. And again, biopsy is getting a piece of tissue, resection is the removal of a larger area. But just like, or there's a parallel here. I'm not going to say just like, but there's a parallel here. You don't start your antibiotics until you have all of your samples collected. And yet in the back of your mind, nothing's going to change until I start those antibiotics. So let's get those samples, people. Let's zippity-doo-dah here. The same is true of cancer. You've got to get all your tissues collected. You need to be certain, because once you start treatment, you forever alter the playing field. So it is imperative that a patient move through these processes of diagnoses relatively quickly, because you can't start the treatment till you've done the collection. And again, it's the treatment that's going to really change all in a number of cases. How do you classify cancer? How do you standardize how to communicate it? And that's what these classifications or grading, if you will. There are multiple different systems out there. They talk about clinical staging. So stage 0 is a cancer in situ. Stage 1, the tumor is limited to tissue of origin, meaning it's very localized in an area. Stage 2, limited local spread, so it's moving out of the localized area, getting a little larger. Stage 3 is it's extensive in the local areas and it's spread regionally. And then metastasis is it's found in other body systems and or organs. And so that, again, getting diagnoses in stage 0 and 1 can improve outcomes. Once it becomes 3 and 4, it gets more complicated. Now the staging, again, it's what does the malignancy look like? What is the histology of the cells? What does the structure of the cells look like? And how big is the tumor and how many areas are involved? And again, staging, there are multiple different staging systems, TNM, which we'll talk about, Duke's, Ann Arbor. They all have their merits. Some may be better in some cancers versus other cancers, but we're going to talk about TNM just for example's sake. So TNM is an acronym. T stands for it's the original tumor, and it describes the original tumor. TX means it can't be measured or found. T0 is there's no evidence of a primary tumor. TIS is it's in situ, IS in situ. It's not started growing into surrounding areas. And then T1 through 4 is the size and the level of invasion into nearby tissues. The higher the number, the larger the tumor is, and the more infiltrative it is. So for instance, a T1 tumor is less than 2 centimeters. N stands for nodes. And so NX again is the nearby nodes. They're not measured, there's not or found, they are perfectly normal. N0 means they do not contain cancer. And then nodes 1 through 3 is the size, location, and number of nodes that are involved. The higher the N number, the more lymph nodes are involved. And M is metastasis. So we've got T for tumor, N for nodes, M for metastasis. MX, again, can't be measured or found. So somebody who's TX, NX, MX doesn't have cancer. It can't be measured, it's not found. Once we get into the zeros, again, you need to look at each one of the letters to see what levels it's at. M0, there's no known metastasis, cannot be found outside of the localized area. And then M1 means there has been metastasis. So you score the patient in each of the 3 categories, T, N, and M, and then an overall stage can be assigned. And again, that is often determined by the cancer itself, whether somebody's a stage 1, 2, 3, or 4, once you have the TNM classification, if that's appropriate. So a woman with breast cancer that's T2, N1, N0 has a tumor. It's more than 2 centimeters, but less than 5 centimeters, which is the definition of T2. N1, there's only 1 lymph node in her underarm that was found to have signs of cancer, but there's no other distant areas. And again, so there's no cancer found in other distant areas. This would be staged as stage 2B breast cancer. And back in the day, you know, staging is still very important. Don't misunderstand me. It gives clinicians and knowledgeable people a sense of what battle is going to come, but it's all about the genetics nowadays. It's the genetics of those cancer cells and how unbelievably specific the therapies are, so targeted based on the genetics, which again goes back to why you've got to collect your tissues before you start treatment. Because once you alter those genetics, you can't go back, and you basically buried the most important information. And then there's tumor grading itself, which talks about how differentiated the cells are. A low-grade tumor is well differentiated. It looks quite different from other cells. And a high-grade tumor equals poorly differentiated, meaning they look kind of similar to other healthy tissues, which makes it harder and more difficult to treat. Because again, when we give a chemotherapy, these treatments, they in fact impact almost all the cells in the body. They happen to have a bigger impact on the cancer cells. But if the cancer cells look more like everyday okay cells, that makes it that much more difficult. So you want a well-differentiated low-grade tumor. Well, you don't want a tumor, but when you hear low grade, it's a better option than high grade or poorly differentiated. You know, let's face it, the word cancer is terrifying. It is one of the last words anybody wants to hear. And whether you're a caregiver or whether you're a family member or whether you're the patient, it is very scary, believe me. So when you're in the role of caregiver, you've got to listen to your patients and their families and let them play out their anxieties. I'm telling you, I'm an advocate that everybody should have a listening buddy with them at medical appointments. That is never truer than when you're talking with an oncologist or talking about a potential cancer diagnosis. Your ability to hear and comprehend is stalled. You need to have a couple of set of ears, ears, EARSs. And I can only imagine how difficult this has been in this age of COVID when visitors, family members are all restricted from coming along. It was helpful on some level to have telemed Zoom conferences with clinicians, because then you could sort of invite whoever you wanted to listen in, if not participate, but certainly listen in. But understand that their ability to hear and comprehend is altered once you say the word cancer. So you need to be concise, you need to be clear, as much written information as possible, so long as they can understand it, and leave yourself open for questions. Because what they think they hear in the moment and what they really heard 4 hours from now are often two different things, very much so. So I talked about the PET scan, and this is one of the gold standard tests. I actually don't, for a number of years, this was so freaking expensive. And I mean, literally, we refused to do it on an inpatient basis. Had to only be done on an outpatient because it was so hugely expensive. But this is a patient who the light areas, I should say the orange yellow areas, are where cancer is being detected by the PET scan. And that's positive something, it's positive. Jean, you know what this is.
Positron emission tomography.
Oh, all right, James, I'll take it from anybody. You know me. Thank you very much. So these are all the areas where cancer cells have been identified by the PET scan. You don't want to be either patient, but in the scheme of things, I think we'd probably rather be the B patient. But again, we'd rather have it all be dark. That would be a much better option. In terms of treatment, there are, like many things, sort of 3 areas that we work on. Cure, everybody hopes for a cure. When cure is either not possible, then we control. And if control's not possible, then we palliate. And so that's not unlike many of the other diagnoses we've talked about. With the primary hope to be cure. And again, with cancer, many cancers nowadays, if the first initial treatment doesn't work or doesn't achieve the ultimate goal, then there is a secondary. And part of the challenge has been, I believe, to keep people alive long enough for new studies, new drugs, new immunotherapies to come either into research, into trials, or to the market to see if they make a difference. And then again, the next stage is, at what point do we say, whether you call it palliative care or hospice? Again, we understand the difference, but at what point do you give the control back to the patient and let them take more control of their remaining days, hopefully months? I talked about how genetics are where it's at, man. This is where cancer treatment is going big time. If you want to work in oncology, you need to become a pretty savvy geneticist in this day and age. It tells us about how important prevention is for an individual. It helps inform diagnosis, and it sure as hell impacts treatment nowadays. In fact, you know, my cousin was diagnosed just at the beginning of this semester with lymphoma, and she had a very fast moving. She's doing really well. It blows my mind. I mean, I'm so happy. She's like my big sister. But if you could have seen her Labor Day weekend and the week after Labor Day, this is a woman who at the age of 64 does half triathlons. So she's running 12 plus miles, she's biking 20 miles, she's swimming 3 miles, and she does 3 or 4 of these a year and trains every single day. And by Labor Day, she had to be helped into the car and needed a wheelchair to go the 50 feet to the doctor's office and all. I've not been that scared in a long time, to be honest with you. And she's back running again now. So what's that? 2 months? She's getting her 4th cycle of chemo on Friday. So and her chemo has changed. In her first cycle, which was back 2nd week of September, it was called EPOC. The biggest gun, strongest chemo, lots of side effects. She did well. But through the last 2 months, they've been getting more and more genetic studies results done. It's one of those things you wish you could wiggle your nose and have them all there right at the beginning, but many of these genetic studies take time. So by the time her 2nd cycle came up, they had more information and they said, you know, we think we could go with R-CHOP. We don't need to do EPOC anymore. Again, another new language we all need to learn. So she had her R-CHOP. She did phenomenally well with that. Much fewer side effects. She looked much better. She started feeling better. This is good. Her 3rd cycle, they made even another change. They were able to alter 2 of the medications. So, and then she was supposed to be admitted last week for high-dose methotrexate. They've decided to push that off to after Thanksgiving. Again, all because of the genetic results that have been coming back on her tumors, on her cancer, all based in genetics. So it's been really interesting to, again, I've been saying this for years in class because I read it. Now I'm living it, and it's amazing. We wish we had this information right at the very beginning and go for the most targeted therapy, but it's expensive, it takes time, and we're always trying to convince insurance companies that this is the best pathway for their patients. And that has been a challenge also. She's got excellent insurance. Once they decide to cover it, they cover pretty much every dime. She's got very small copays. but getting them to decide to cover it can be a full-time job. And she's got clinicians who are working consistently on that. I hate to say she's got me, but I can say this is the way you need to present it to the insurance company. Use these words. Make sure these words are in the medical notes, because I know what insurance companies want to hear. And then she's like freaking smart too. So it's getting done, but it's, she's got to go for a PET scan this afternoon. And she just got notice last night at 10 p.m. after 6 weeks of fighting with insurance that they're going to cover it. What do patients do when they don't have those resources? They're relying on us to be their advocates. Shouldn't be like that, but it is. So we need to really be aware of that. I think that's important. Treatment, again, surgery to remove tumors, surgery to place your tunneled central venous access devices, radiation to help shrink tumors, chemotherapy to both shrink and kill cancer cells, bio and immunotherapies, again, to prolong life, to assist cures, and in some cases, stem cell transplants, where the stem cells can convert to what's needed in the body. Okay, we know what a biopsy is. Excisional biopsy is you're taking a small piece of the tumor. A debulking procedure usually means that the tumor is either so large or has become so invasive that removing the entire tumor is not possible. They're going to they're going to surgically remove as much of the tumor as possible without permanently destroying function. They want to improve outcomes, but debulking does not mean they're going to get everything. They're going to get as much as they can while restoring function, minimizing long-term damage, and hopefully improve outcomes. But debulking is usually, there's a lot more work to be done after a debulking surgery. And then we have preventative surgeries. When you go for your colonoscopy and they cut off some polyps that they believe have the potential to become malignant, that is preventative. Again, being able to remove an entire tumor or local lymph nodes can be a very positive curative thing. And again, palliation is where they may go in, they may do a debulking, they may do a removal. It's not going to be curative at this point, but it's going to help relieve symptoms, whether it's pain, obstruction, whatever the case may be. But a palliative surgery is to minimize symptoms that patients are having to help relieve complications, as I say here. And then oftentimes we need reconstructive surgery afterwards. If tissue's been destroyed, if it's been so much of the tissue's been removed, and they have to go back in and reconstruct the area to help the patient. Anti-neoplastic drugs, chemo, that is specific for cancer. Chemotherapy is essentially any chemical used as a therapeutic agent. So even the metoprolol you give or the Norvasc or whatever pill you're giving is a chemotherapy. But it's the anti-neoplastic drugs that are specific for oncology purposes. nitrogen, mustard, and so anti-neoplastic drugs have only been around since 1942. They tend to be highly toxic chemicals. Again, they often work on all the cells of the body or many of the different cells of the body. They happen to work harder and better on the cancer cells. But this is why there are so many side effects associated with many chemotherapy, anti-neoplastic medications, because they're not only working on the cancer, they're working on other cells as well. Chemotherapy can often be curative for many types of cancers: testicular, Hodgkin's lymphoma, ALL, neuroblastoma, Wilms tumors. It's used to control different cancers like breast cancer, non-Hodgkin's, small cell lung cancer, ovarian. And then chemotherapy is used to palliate, to relieve pain, obstruction, and improve patients' health status. And so again, in many cases, the chemotherapy, the anti-neoplastic drugs are not selective on the cells they're going to kill. So we need to realize that other particularly rapid dividing cells, like here in the GI tract, bone marrow, gonads, are typically highly impacted by different anti-neoplastic drugs. This is why patients lose their hair when they get chemo. This is why nausea, vomiting, diarrhea are common side effects with chemotherapy. Why it suppresses bone marrow, and so blood cell counts often plummet post chemotherapy, and why the risk of sterility is possible with different chemotherapeutic agents. They also often use more than one. They're often used in combination. Again, EPOC was a combination of 5 different drugs. R-CHOP was actually the same 5 drugs, just different ratio of the doses. When we talk about adjunctive therapy, it means it's in addition to. So there's some other primary therapy, primary drug, primary treatment, be it surgery, radiation, whatever, and then adjunctive therapy is given in addition to. Neoadjunctive therapy is given in advance of a primary treatment. So neoadjunctive is often used as radiation can be done in advance prior to surgery, prior to initiating some chemotherapies. And then myoablative drugs help to literally, this is when we give myeloablative drugs, we are purposefully shutting down the bone marrow. We want the bone marrow to stop producing cells because it's producing cancer cells. So let's shut it down. This is what we use pre-stem cell transplant. And then once the patient's bone marrow is at a standstill, they reintroduce clean, healthy stem cells and then spark the function of the bone marrow again, hopefully to come up with new healthy blood cells without the cancer. Sorry. Some chemotherapies, more coming orally. Vast majority are intravenous. Can be given intramuscularly, subcutaneously. Intrathecal, again, that's going through into the CSF. So they'll do a lumbar puncture. They'll leave a catheter in and they'll administer chemotherapy into the CSF, into the spinal cord for CNS, either treatment or protection. They sometimes give intra-arterial right into the hepatic artery, often for liver cancers. Intravesical into the bladder, topical. So a bunch of, the routes of administration are many. Here's an example of why central venous access is critical. These drugs are highly destructive to tissue. They need to be given via central venous access. And so every patient, and in oncology, because it's often a longer term need, it's a combination of reasons. Longer term need, the access is protected because it's under the skin. It can be closed off for long periods of time and doesn't need to be reaccessed if it is anticoagulated properly. So they use a lot of, oh Jesus, it just rolled out of my mind. What's the one? Portacaths. It also helps with body image. They don't have this long plastic tube hanging out of their body. To administer chemotherapy, most organizations require that you be chemotherapy certified. It's typically offered by the organization. They, at your organization, will determine what they want for somebody to be chemotherapy certified. But you can also, of course, become an accredited oncology nurse. If you're working in oncology. And I strongly encourage you all to think about getting accredited in the area, certified in the areas where you are working, whether it's critical care, emergency department, med surg, oncology, rehab, whatever your thing is. I want you to go on to graduate school, as you know, but you can always start with certification in your specialty area. In terms of handling chemotherapy, that's usually guided by both OSHA and the ONS, Oncology Nurses Society. Chemotherapy needs to be mixed in the pharmacy under the hoods. Again, you don't want to breathe in these chemicals. You don't want to touch these chemicals. You need to protect yourself. You need to protect everybody in the environment. So these are not things that you're mixing on the floor like in antibiotics in an mix bag. They often have non-absorbent gowns that they use when they're administering chemotherapy and working with body fluids. And again, the integrity of your gloves are important. Eye and face shields to protect against splashes are important. And then how to dispose of the bags and the tubing is also important. So there are special containers to dispose of chemotherapy bags. We need to make sure that any spills are handled per protocol. They often have specific spill kits on oncology units. Your syringes, bags, tubings, again, need to go into the chemo hazardous waste areas. And again, using face shields and gloves when disposing of body fluids for certain chemotherapy agents is important also. Methotrexate is a very old drug. It's been around, I don't know since when, but I remember learning about methotrexate in nursing school. So, back when God wore short pants, right? So it comes in a pill. Some people take it I remember, again, administering it on the floor. You didn't even need to be chemo certified to give PO methotrexate. Carolyn got, when she got her first cycle of chemo inpatient, she got 1 dose of methotrexate intrathecally, again, via a lumbar puncture. Then now she needs another dose after Thanksgiving, but it's going to be very high dose. And although the administration, the infusion only lasts 3 to 4 hours, it is critically important that it be cleared out of her system before she can be discharged, because it is so nephrotoxic. So this, even though for a 4-hour infusion of methotrexate, it requires a 3 to 4 day hospitalization for clearing out the byproducts of the methotrexate so that you don't end up in renal failure. So they'll be testing her urine. She'll be drinking and peeing like crazy. Good times for our weekend after Thanksgiving, right? Again, if you're looking to become chemo certified, you're going to understand to be able to pronounce the names of the drugs. You're going to know what the typical regimes are. And very importantly, you're going to be able to anticipate side effects. The importance of educating the patient and the family so that you minimize that fear of the unknown. That's very important. Follow your lab values, they know at what day to expect what changes in lab values, whether it's the platelets, the white blood cells, the red blood cells, whatever it may be. Again, these are often drugs that require a second RN signature prior to administration. And managing those side effects, whether you're using, what do we do for nausea? Ugh, we all know it. It'll come to me. Give me a minute.
Zofran?
Zofran, thank you. Appreciate it. Zofran. If you need to move to prochloromidine, compazine. Sorry, I'm forgetting the other names. If you're on high-dose Zofran, you better be on a bowel regime. I had no idea how constipating Zofran is. You need a bowel regime if you're going to be on regular Zofran. Who knew? I guess I should have. But once I read it, I'm like, oh, we need to add this, girlie. You need to administer, and then, be aware of people's pain. The pain is not necessarily related to the chemotherapy, but pain was clearly played an important role in both my father and my cousins, and you see so many patients. We've learned so much about pain management and palliation from oncology patients. It's just so important. Again, watching for other side effects over time, whether you're protecting them from low platelets, whether you're protecting them from low white blood cell counts, other anemias, and then make sure your documentation is solid also. About 50% of patients, oncology patients, do receive radiation treatment. And again, this can kill cells. It can be both used for direct treatment to cure. It can be used as a prophylaxis. So there are many reasons to use radiation. You want to be able to deliver very precise radiation so that the dosing is just right to minimize side effects. You want to deliver it very precisely so that surrounding tissue damage is minimized. But it is, again, this is a highly specialized area unto itself. Radiation is typically administered 5 days a week, anywhere from, I say 2 to 8 weeks, but it can certainly be longer. They use a lot of immobilization devices so that during the treatment itself, patients stay absolutely still. Again, the whole point is to deliver the targeted beam to a very specific area to minimize damage, maximize damage to the cancer cells, minimize damage to localized areas. Patients are often marked up quite specifically to help target the beam of the radiation. And it's important that the patients, the families, and everybody around knows that those were not just the artist's drawing and entertainment, that those markings are really important and should not be washed off. Until treatment is completed. Those markings are literally guiding the therapy every time they go to radiation. External beam radiation, that's where, again, you're from an external source shooting it at the area. And then we talk about brachytherapy or internal radiation. This allows us to get radiation very, very close to the tumor, sometimes either adjacent or through the tumor. And so, or the area where the cancer is. They have radioactive beads that will be placed in or near, as I said, the tumor or the area where the cancer is. This is often done inpatient, because the patient has radiation in them for X amount of days. So that while these beads are in place, the patient themselves is radioactive. And needless to say, all sorts of care needs to be taken place when caring for that patient. Once the beads are removed, the patient's no longer radioactive and not at risk, but while those beads are in place, you have to be aware of that. So when you're caring for patients like this, like all radiation, you need to limit the amount of time you're near the patient. You need to limit the distance in terms of how close you get to the patient. You need to organize your care so that you're being goal-driven every time you enter the room. I have used shielding here because, as far as I know, I did look, they have not changed the standard yet, but they are changing the standards for where and when to use shielding, particularly over the reproductive areas, the ovaries and the testicles. Most places no longer shield the patient when they're getting a chest x-ray or something like that. And if you're working with a patient undergoing brachytherapy, you should be wearing a film badge that's going to monitor your exposure, and so that your radiation officer can track your exposure as well. So again, external beam machines, there's no risk. So as you're outside of the room where the beam machine is, there's no risk. But people in general who are working down in diagnostic imaging or radiation therapy are wearing film badges to monitor their exposure. If you're caring for a patient with brachytherapy, what radioisotope is being used, is it sealed or unsealed? You need to know these things about this patient for part of not only patient education, but your education. And that should be documented in the medical record also. So when we're talking about safety, radiation safety, it's time, distance, and shielding. How long have you been exposed to the radiation, or in this case, the patient? And it should not be more than an hour per person per shift, which means you need to be very organized when you're providing care to this patient. How far away are you from the patient, distance, or the source of the radioactive material? The farther away you are, the safer you are. You should strive to stay 3 feet away if at all possible. And again, shielding as appropriate. I had another friend who she had a benign tumor, and the sucker just kept recurring. It was a highly unique case. They originally thought it was definitely malignant, but it wasn't. She ended up having brachytherapy to shut down this benign tumor. And at that time, the only place they were doing brachytherapy was on the GYN oncology floor. So she gets admitted for this bone tumor to the GYN oncology floor. And of course, we all set up, she worked with us in the coronary intensive care unit. So we, of course, set up Party Central in the hallway. They wouldn't let us into the room. And we basically tortured them for them being the staff, the 4 days she was inpatient. But for us, it was about keeping her healthy and her mental status happy and stuff like that. And again, I'm pretty certain that would never happen today, but bad situation made better because we had fun. Some of these implants can fall out, especially when they're placed in the cervix, or I should say in the uterus, they can fall out. We need to make sure the radiation safety officer is called. We need to call the radiation therapy physicians. You may want to take them. There should be a lead container in the patient's bedroom. There should be emergency forceps kept in the patient's room so that they can be taken out of the bed so the patient isn't exposed other areas of their body, and they can be placed in the lead container. But everybody needs to know that the beads and the implant have come out. I call them beads, but it comes in various different implants nowadays. In the event that a patient cardiac arrest needs a rapid response, needs respiratory support, you suspend precautions, and then the radiation safety officer meets with responders and talks about what each person's exposure was. Trash, linens, food trays stay in the room. Those are discarded and dealt with through separate channels. They don't get mixed in with the general garbage or linens of the general, the floor. Dressings and other linens should be again kept in the room and discarded per your organization's protocol, but they're not mixed in with the general garbage or linens of the hospital. And most of what goes into that room is all disposable. You really don't want to bring stuff in there that you need again because it's been exposed usually for a prolonged period of time. Again, going into the room, gowns, shoe covers, double gloving. If you're worried about respiratory symptoms or any sort of splashing of body fluids, masks, face shields, hair coverings, and we definitely want the patient to shower if at all possible throughout the stay. Little bit about immunotherapy. Again, this is so important to the future of cancer treatment, especially from what I've read and what I understand. Immunotherapy is really providing prolonged life with far fewer side effects for many, many patients with many different types of cancers. whether it's called immunotherapy, biologic therapy, though I'm sure there are subtle differences, but for my purposes, I use those interchangeably. But you're really looking to get the immune system to do its job and to shut down the cancer as best as possible. And the beauty of, and again, because it's so significantly genetically based, it typically attacks the cancer cells directly, which from a side effect perspective is really good news.
Hey, Carol Ann?
Yes.
So Juan and I are doing our community health clinical at a urology clinic up in Yale.
Yeah.
They do a procedure called BCG, which stands for Bacillate Calmette Guerin. And it's immunotherapy where it's a weakened version of TB.
Yeah.
That they enter through the urethra for bladder cancer.
No kidding.
Yeah.
Doesn't this, again, I mean, I sound like somebody straight off of, I don't know where, but who the hell thought of that? You know, I think we could alter TB and it will work really well for bladder cancer.
Right.
How do the patients do? What are the side effects?
They have to keep it in their bladder for 2 hours when they go home, and then they finally are allowed to urinate. And then after they urinate, they have to clean up with a bleach and water composition to make sure that no one else, touches this stuff because it's obviously very bad.
Yeah.
They get 3 to 6 treatments. Three normally works, but sometimes needs as much as 6, and they'll do it on a weekly basis.
Uh-huh.
That can cause nausea, vomiting, some confusion, side effects, and it could be pain in urethra to urinate.
So this one sounds like it does have more side effects than some other immunotherapies that are available. And again, I sort of just, and again, I should know the answer to this, and if I thought it through, I would, but why would putting something up into your bladder cause nausea and vomiting?
I don't know.
Exactly, but that seems to be a reasonable question by a patient and their family. So that's something I would need to be prepared for when they asked it, because it's not obvious, Thank you for that, James. I appreciate it.
Yep.
So some of the targeted therapies, again, there are flu-like symptoms: anorexia, weight loss, malaise, nausea, vomiting, photosensitivity. But I will also say again that the use of these substances has done tremendous work in prolonging life for patients with many cancer diagnoses. In terms of side effects of cancer treatments, it's a long list. They talk about chemo brain, where they're just slightly foggy, can't remember things as easily as they used to, and this can last essentially forever. It's certainly not just while you're getting the chemotherapy. Peripheral neuropathies are very common with many of the chemotherapy drugs. Many of these drugs are cardiac toxic. So folks are going to have echocardiograms before they start these therapies. And so changes can be recognized. And we can, if you will, blame the chemotherapy or track the effects of the chemotherapy. We talked about earlier how pleural effusions are often seen as part and parcel of symptoms of cancers. Well, pleural effusions and pneumonitis are also side effects of cancer treatments. Infertility, amenorrhea. Again, we talked about how many chemotherapies impact fast-growing cells. So mucositis, this is the, although we think of it in the mouth where they get big sores in the mouth, which can be very painful, very difficult to eat. And here, these are folks who are already anorexic and nauseous and just don't feel well. But now they've got big sores in their mouth because of, as a side effect of the chemotherapy, further making it difficult for them to eat and drink. Diarrhea, constipation, cystitis, infections. Again, the infections, the way many of these chemotherapeutic drugs impact the bone marrow, the fact that they're pancytopenic is very common. Interestingly, we talked about what's the drug to stimulate red blood cell production that we use a lot with renal disease.
Erythropoietin.
They have a similar drug that stimulates white blood cell production. Neulasta, there are a couple of other names for it, to stimulate white blood cells production so that patients can fend off infection. What they have found with cancer patients, though, using erythropoietin in many types of cancers, particularly lymphomas and some leukemias, using erythropoietin actually perpetuates the cancer and undermines the impact of the chemotherapeutic agents. So they'll often let people be red blood cell anemic and not treat them with erythropoietin and just use blood transfusions instead. Didn't know that. Just learned that. Again, nausea and vomiting. Almost everything you do to an oncology patient can potentially cause nausea and vomiting if the cancer itself didn't cause it. Again, it's often because of a CNS stimulation, the vomiting center in the brain. From a peripheral perspective, serotonin gets released from the intestinal cells. So we know that many chemotherapies cause nausea and vomiting. So you need to pre-medicate these folks. You need to do it in advance. You don't want to wait until they're already nauseous. Just like pain, you need to stay ahead of it. And so that's actually absolutely critical for these folks. Prevention's better than the treatment. Medicate folks around the clock. The Zofran actually is a serotonin receptor antagonist, and again, the impact has been significant. There are far fewer CNS side effects than with Zofran and Kytril than you have with the compazines and other things like that. They use steroids, anxiolytics, a little bit of Xanax or the A one. What's the anti-anxiety that begins with an A? Lorazepam.
Ativan.
I got it before you. Thank you. Of course, I knew what I was looking for. And again, these folks, you got to leave the smells out. Don't be wearing heavy perfume. Don't be using heavy chemicals around these folks. The flowers, the things like that. No smells, nothing that's going to trigger more nausea and more vomiting. Anorexia is a huge issue, not only because of the nausea and vomiting, but because of the changes to the taste buds, and nothing tastes good. We've got to keep these folks from becoming dehydrated or malnourished. So we want heavy calories, high proteins. We don't want them getting into a deficit situation. So We need to work with the dietitians. We need to work with the family. We need to figure out what's going to entice them. Small, almost constant meals, whether we're using supplements once they get to a 10% weight loss. But again, we want them to be high quality, high calorie, and typically high protein because it's going to promote healing. Again, and that's all things being equal and all our other organs working relatively well. In extreme situations, we can add TPN, but that's certainly not preferred because, of other stressors that brings to the body. So again, our GI assessment needs to be thorough and detailed. We need to particularly know what their bowel pattern was when they were healthy, what it is currently, and we need to keep it as close to their healthy routine as possible. And then again, we need to plan for and anticipate nausea, vomiting, and treat it in advance. Don't wait till it becomes a big problem. We talked about mucositis and the sores of the mouth and how that undermines nutrition and pain management as well. I think we've got this. Relaxation, imagery, distraction, all of those things. Again, not everything can be cured at this point in time with a pill or a medicine or something. So we need to help patients harness their own strengths. And whether we're doing relaxation or imagery or distraction, what we need to help patients use those tools as well. We talked about small frequent meals, high calorie, high protein, just don't smoke. And drinking your calories is not typically a good plan, either short-term or long-term for sure. Alopecia, this is a big deal for a lot of folks. Doesn't happen right away, usually takes 2 or 3 weeks. And interestingly enough, certainly not all drugs cause hair loss, and not all people even taking the same drug will lose their hair. But it's still something that impacts many chemotherapy patients. Again, it will grow back in 2 to 3 months once therapy is over, and Connecticut law requires that insurance companies cover, as it says here, cranial prostheses in Connecticut. And there is no way to prevent hair loss that anybody has come up with that's consistent. Skin's a big deal. How many slides do we have left? Can somebody tell me? Do you want me to finish up this section, or do you want to take a 15-minute break? Now.
I prefer you to finish it.
Okay. Thank you, Kevin. Either that or everybody else has already gone out on break and it's just you and me. I guess that's possible. All right, so skin, many of these drugs, radiation, make people more photosensitive. But again, in terms of prevention, we need to manage our sun exposure. So sunscreens, sunglasses, and hats should be used all year round. If you've got erythema, particularly from either a radiation or a topical medication, again, you want to avoid constricting garments. You want to protect that area. You don't want to use harsh chemicals or cleansers or deodorants on that area. You may end up with hyperpigmentation of this area post-treatment. And then during treatments, you worry about both dry and wet desquamation, and we'll talk about that more in a little bit. And you are subject to hair loss with high dose radiation. And it doesn't have to be for a cranial tumor either. High dose radiation definitely causes permanent hair loss, which is even more scary than temporary hair loss from chemotherapy. So dry desquamation is this redness. It's almost an external burn of the skin. This is not open, but the skin is very tender. Those cells have undergone different changes. And then wet desquamation is an open area. And obviously there's some skin sloughing and all, and these are wounds that are specifically related to the administration of radiation. It can be very painful. And again, you want to clean these areas gently. You don't want to use chemicals on them, and you're going to get your wound care folks involved for some guidance on managing some of these wounds also. So doing a skin assessment is really important. You're looking for rashes, you're asking about itches, you're looking for erythema, tenderness. You obviously are checking your IV sites, petechiae, bruising, all those signs of low platelets. You need to check the perineal area for a variety of reasons. You know, if the patient has had or is anticipating brachytherapy for GYN cancer, again, that's going to be a high risk area. Number two, it's also, you know, these are patients who are fatigued, they have malaise. Are they able to keep up with their activities of daily living and keeping themselves clean? Also, if they have a decreased white blood cell count and they're having some trouble fighting off infections, well, we know warm, dark, moist areas are where lots of different things like yeast thrive in those areas. So we need to check the perineal areas. And it's about education. We want to use mild soaps, lotions, nothing with any scents or things like that. Avoid the sun, use sunscreen, and make sure that they keep their providers in the loop. Anticipate changes and reactions, skin reactions. Let the patients know, part of our patient education. Making sure skin stays clean and dry. What are the right products that can be used? And particularly when they're getting treatments. In most cases, skin should be clean and dry with no products on them. Particularly deodorants. Many deodorants, antiperspirants have aluminum in them, and this can be highly serious when you mix that with radiation. So we want them to be clean and dry, free from any sort of products. Water-based lotions are probably better than oil-based. Lanolins are okay. Again, the use of sunscreen. And again, the use of sunscreen should become an everyday habit for everybody. You don't want to be using adhesive on those areas. It's just going to further impact the skin. Avoid shaving. They should be using a clippers if they need to do any sort of hair removal. And don't wash off the radiation landmarks. Those need to stay throughout the treatment time frame. Patients with cancer are tired. That may be one of the most significant side effects or complaints. And it's multifactorial. Number one, the cancer itself is using an awful lot of energy to perpetuate itself. The treatments are incredibly exhausting also. So they need to conserve their energy while still being as active as possible. They need to figure out when they feel well and maximize that time for whatever movement and activities they want to engage in. And the more they maintain their hydration status, the more they maintain their nutritional status, over time, the better off they'll be. And just because every cancer patient says they're tired doesn't mean you don't look for an alternate or reversible cause. Again, think about anemias, think about low intake of protein and things like that. Let's work when we can alter a situation. Let's do our best to alter it. So preventing infections, again, the use of the white blood cell drugs, Neulasta et al., have really made a significant difference for these patients. But again, keep a clean living space, avoid people who are sick. Everybody needs to practice good hand hygiene. A daily bath and oral care is incredibly important. While prophylactic antibiotics may not be de rigueur anymore, what almost every patient will be taking are antivirals. And so prior to starting any sort of chemotherapy regime, they'll usually be started on an antiviral medication. We want to protect the rectum. We know perforated rectums are going to come to no good in people who have impaired ability to combat infections. And again, the Neupogen, Neulasta are the stimulating drugs for the white blood cells. Patients need to know that we need to know about temperatures above 100.4 or below 97 degrees if they have any shaking, chills, tachycardia, tachypnea, hypotension, mental status changes. Again, so many of these things fall into the SIRS criteria. And so they should have a low threshold to call their clinician with these signs and symptoms. Skin breakdown, abdominal pain, poorly controlled diarrhea, even with my cousin's nausea, which was intractable in her first month. They wanted her to call every day with an update, just to see what was going on and to hear her latest, even if it wasn't particularly different from the day before. Again, stay away from sick people in crowds. Be careful in terms of caring for your pets. Some pets are, again, birds, not good house pets for people with poor immune system. They shouldn't be changing the cat litter. Things like that they need to know about. They need to practice good mouth hygiene. Everybody needs to practice that. But again, soft bristle brushes, good mouth washes, things like that that aren't going to dry out the mucosa of the mouth, but help keep it intact. Food safety. They're a lot less rigorous about avoiding raw fruits and vegetables. But again, they do recommend that you cook your foods thoroughly for the most part. Make sure your ANC, your absolute neutrophil count, is above 500 if you're going to engage in anal sex or other, practice safe sex once your ANC is above 500, and know when to call the ED and when to call your physician, when to go to the ED. So these are when to call, again, elevated temperature, chills, rigors, new mouth sores that are preventing you from eating and drinking, perineal pain, pain with elimination, cough, shortness of breath. These are signs of infection. They are signs of tissue damage. These are all things that could potentially become bigger problems than the cancer itself. External beam radiation does have long-term chronic side effects. The skin changes, that hyperpigmentation of the area, other, atrophy, it's almost scarring, if you will. It can cause adhesions in the GI tract, which leads to obstruction and other strictures. Permanent taste alteration, xerostomia, again, are mouth sores, I believe. I need to check on that one. Pulmonary fibrosis is a chronic side effect of beam radiation. Secondary malignancies, actually many chemotherapies as well as the radiation can in fact leave you open for other cancers in the future. And then in younger kids, slowed growth, hypoplastic bone changes can all impact children's future growing abilities. And the secondary cancers are things like leukemia, angiosarcoma, and skin cancers. Talked about the patient's state of mind and what a devastating word and situation a cancer diagnosis is. So to anticipate some level of depression and anxiety, which we know tend to go hand in hand with each other, is almost inevitable. Whether it's the fear of the unknown, loss of control, the financial burden. Again, this is something I've talked about and I've known about, but to live it is unbelievable. Being asked to go to the hospital for different tests. At one point, it was every day she needed to show up at a lab or the hospital for something. She was unable to drive herself. So how is she going to get there? What if she had a job that didn't allow her that level of flexibility? What if she didn't have some pretty freaking amazing insurance? How do people manage these things? Again, she had friends and family who rallied so that food was being dropped off. She had more rides than she, offers for rides than she needed. But not everybody has or lives in a community that has that level of flexibility. And then, of course, there's, fear of death, which impacts most people fairly significantly also. Body image issues can be very significant. That's where the hair loss comes in, the anorexia, all these changes, and the sense of self. Again, people who what they do every day is really very much a part of them. And what do they do when they can't do that? How do they view themselves if they can't do what they love anymore? So there are usually social workers that are very active in the oncology team. Usually the chaplains spend a fair bit of time in oncology as well. And you, as the nurse, become your patient and their family's confidants as well. And then again, the fallback in terms of support groups as well. And again, initially they may not think that may be for them, but to encourage them to give it a try if you need to harness more resources. Oncologic emergencies, and there are life-threatening emergencies related to cancer, and it could be whether it's the disease itself or treatment, but they are definitely things that we need to talk about. So obstructive emergency, superior vena cava syndrome. This is where either a tumor or such a large thrombosis forms in the superior vena cava and obstructs blood flow. What this looks like is facial periorbital edema, head and neck veins become distended, ultimately seizure, and headache can ultimately seizure, but headache also. This is a really significant common problem. We know patients with cancer diagnosis are at greater risk for developing thromboses, and whether it's tumors of head and neck cancers or tumors from lung cancers that are obstructing that superior vena cava. But again, that facial periorbital, and it's usually on I'm pointing to the left side, but it's usually on the right side of the face and that arm as well. Spinal cord compression. With spinal cord tumors, again, we know that the blood flow throughout the spinal cord is absolutely critical. All of those nerves in the spinal cord need the blood flow. When a tumor increases in size and obstructs blood flow, it's going to cause a spinal cord stroke. Early signs are back pain, over time lower extremity weaknesses, paresthesia, loss of motion, and changes in of the lower extremities, and then changes in bowel and bladder function. And again, for patients who are on anticoagulants, you worry about spinal cord compression due to hematomas within the spinal cord as well. Third spacing syndrome. Again, we know what third spacing is. This causes hypovolemia, hypotension, tachycardia, because again, patients got all this extra fluid, but it's in the tissues. It's not usable. It's not circulating, but it's become something that is making it very difficult for the body. And again, because of usually the decreased protein, giving fluids just seeps them into the interstitial space. So we need to improve protein status. We need to use diuretics judiciously. Managing oncology, third spacing is the same as managing it in extreme heart failure or liver failure. It's difficult. Metabolic emergencies we talk about are syndrome SIADH, where the ADH is increasingly secreted. Hypercalcemia is a huge, significant oncologic emergency, and usually goes hand in hand with tumor lysis syndrome. What happens is usually with the administration of chemotherapy, you're obviously going to be looking for that chemotherapy to be working on the tumors specifically. If that chemotherapy is working particularly well and these tumors are breaking up or lysing, as those tumors break up, all these toxins can be secreted into circulation, often resulting in hypercalcemia. So they're doing regular electrolytes, looking at electrolyte balance on a regular basis. Septic shock with bone marrow suppression, white blood cell suppression, we worry about septic shock. And then DIC. DIC is often caused because of really if you remember that DIC cascade, which I don't really want to bring you back to that low point in the semester, but you know, cancer ends up causing significant subtle changes to the clotting cascade that leads to DIC. So here you have this overwhelming hypercoagulability of these mini emboli. And so the platelets are all used up, and yet the patient is bleeding because there's no platelets to go to where they're actually bleeding from. Again, we know SIADH, it's either an abnormal or sustained production of ADH, and many cancer cells are actually able to mimic and or release ADH. And when the chemotherapy comes in, that stimulates this release, hence the syndrome of inappropriate antidiuretic hormone. Again, holding on to fluids, not peeing them out. So that means we need to watch our patients' urine outputs. The other cause of hypercalcemia is a parathyroid hormone-like substance that can be secreted from cancer cells. We know what the signs of hypercalcemia is: depression, fatigue, weak muscles, EKG changes. So again, we need to be on the lookout for hypercalcemia. And again, tumor lysis, I described that, where the cells are being destroyed in large numbers. So I said hypercalcemia. Tumor lysis leads to hypocalcemia. I'm sorry. But you get increased phosphate, which causes decreased calcemia. So again, watch your electrolytes and your renal function in patients. 4 things we look for with tumor lysis: hyperuricemia, hyperphosphatemia, hyperkalemia, and hypocalcemia in the first 24 to 48 hours after chemotherapy, but you need to be on the lookout for almost a week after chemotherapy. So those 4 H's of tumor lysis, all related to electrolyte balance. And DIC we talked about. Other problems we worry about: cardiac tamponade. Again, we know pleural effusions are an issue with cancer. We know that effusions in the pericardial infusions are a concern as well. When pericardial infusions increase or a tumor is within the pericardium, we know that the potential for cardiac tamponade increases. Again, cardiac tamponade is that constriction of the pericardial sac. If it's fluid, we need to tap it out. So we need to, again, we're assessing, listening to our heart sounds. Are they clear? Are they decisive? Are they muffled? And again, what were they like when they were feeling well? What are you hearing now? So being able to compare as time moves on is important. You can drain a pericardial effusion just like you drain a pleural effusion. And in both cases, you can leave a catheter in those areas if the belief is it's going to be a recurrent effusion. You don't need to acutely go in and place a drain each time. You can leave a catheter in so that it can be drained on an as-needed basis. One of the worst cases I saw, and it was particularly poignant because it was a Christmas Eve, but this was a gal who was well known to the oncology service. She had breast cancer. And she had youngish children, like early 20s, late teens, college age, and just was not able to give up, was consistently looking for a cure, was not able to work with palliative care or hospice. And oh my gosh, this gal had fulminating wounds where the tumor had actually broken through the skin and had come up her neck. And she came in on Christmas Eve and had a carotid artery rupture. And so you had this foul smelling wound. You had a carotid artery that was pulsing, that we were maintaining pressure on. And it was just one of the most horrific scenes I'd ever seen. And you know, the family all knew what her wishes were. They were all on board, and they just wanted something to be done to save their mother. And so the woman was taken up to the OR. And to be honest with you, I have no idea what the outcome was, but I remember, I was triaged that day. I wasn't in the back, but when she arrived, to say I smelled her coming, and I think that was the first time I really understood and had connected the smell of a fulminating oncology wound. I literally, like, they opened the back door of the ambulance, and I just about keeled over. This smell was unbelievable. But again, she also had ruptured her carotid artery because of the invasiveness of the tumor and the wound, and it was a terrible way to spend Christmas Eve for everybody, let's just say. What does cure mean? And so again, remission is the period of time where the cancer is responding to treatment and is under control. In complete remission, the signs and symptoms of the disease disappear, and cancer remissions may last for many years and be considered cures. But I think given the way chemotherapy works, given the way radiation works and these long-term immunotherapies, patients who have had cancer are always looking over their shoulder, and they are certainly always being checked for either a recurrence or a new cancer. So they can never, it's something they're always on some level aware of. But the reality is there are millions and millions of cancer survivors in the United States. 64% of adults cancer, if they're diagnosed today, can expect to be alive in 5 years. And the majority of cancer survivors are over 65 years of age. Most 1 of every 6 people over 65 is a cancer survivor. 79% of childhood cancer survivors live 5 years after their diagnosis, and 75% are living 10 years following their diagnosis. So there are many, many great statistics and reasons to be very hopeful and optimistic about the future of cancer. And as I started off saying, the reality is cancer is going to impact us all at some point in time, one way or another. And folks who have been diagnosed with cancer, they need to understand how important it is to stay connected with healthcare and to keep on going back for treatment, for assessment, because the risk of either recurrence or a new diagnosis is not nominal. So stay connected with healthcare. It's really important. All right, guys. Oof, that was a long time. I apologize. I don't usually keep you that long without break, but we have more to do. So it's 10:39:40 right now. Why don't you guys take 15 minutes? I'll see you back here at 10:55.
Okay.
I'm going to
Thank you.
pause our recording. And we'll get started on fractures, a somewhat, I'm sure the orthopods in the world would disagree, but somewhat less complex environment, if you will. So we know a fracture is a break in a continuity of the bone. Usually fractures come from traumatic injuries, but again, you can have these pathologic fractures, whether it's due to a cancer or osteoporosis or something like that. And we taught, they're all different ways to classify fractures. So an open fracture means that there's a part of the bone coming through the skin. And maybe it was something that started external and went in, opened up the skin, landed on the bone, and created an open fracture. Or maybe the bone broke and a sharp edge came out through the skin. Anyhow, how that happened is less of a concern than just to know that is considered an open fracture versus a closed fracture where the skin is intact around the area of damage. Then one of the next questions is complete or incomplete. A complete break is it's all the way through the bone. They are now separate pieces, if you will. Incomplete means there's definitely a break in the bone, but the bone is still connected at some point in place. It's still one piece. Displaced versus non-displaced is the next way to describe a fracture. Displaced means the alignment of the bones is no longer intact. The ends are separated from each other. Non-displaced mean there's still some level of alignment, and again, the periosteum is what they call intact. So it is a straighter fracture, if you will. And then how do you describe the line of the fracture? Linear, oblique, transverse, longitudinal, spiral. And here is a picture which I find a little bit easier to help understand those. Transverse, again, sort of a straight across, if you will. Spiral, usually created from a twisting of the bone, where usually one end of the bone is either stagnant, staying still, and another area is twisting, or they go in opposite directions. Green stick, this is used in younger children where bones are still pretty soft and, soft and malleable. Might not be exactly the right words, but think of a fresh twig on a tree or a bush. Older twigs snap and come apart. Fresh green twigs snap, but they stay intact. They rarely have, it's more difficult to get a complete fracture. And so we use the term green stick just like we do with trees and saplings and things. Comminuted is where there's multiple different pieces. Oblique, again, not intact, but like a spiral, and it tends to be more longitudinal. And pathologic, again, an area of weakness in the bone, whether it's from a tumor or osteoporosis. And then oftentimes in the feet and the lower extremity, stress fractures where overuse can cause some compression fractures. And again, this is just a picture of, again, those same terms for the most part. Impacted would be a new term, though. This is where a bone is pushed into itself, if you will. It doesn't really telescope into it, but again, it tends to be an aligned fracture, but again, usually by force. You see a lot of impacted fractures. I always think of the people who jump in a suicide attempt, or perhaps a rescue attempt. Classic sign of jumping injuries like that are calcaneus fractures and impacted fractures of the lower extremity. And we had a resident once who was running to a code, didn't realize, he thought he was close enough behind whoever just went through the door in front of him. He didn't realize the door had latched. So he ran into the door straight armed, and he had an impacted fracture of his upper arm. And unfortunately, it was his dominant arm. And so that's how you end up getting those sort of fractures. Displaced, non-displaced, and then an avulsion. This is a fracture of the bone, a small piece of the bone breaks away, and one piece becomes loose and floating, if you will. More typically on the ends of the bones than in the middle, if you will. In the skull, we talk about a depression fracture. Again, something hard hitting so that it creates a concave area of the bone. On the face, you can get depression fractures as well. So from an assessment perspective, what are you looking for? How do you differentiate a muscular injury from a bone injury? And it can be difficult. Thank goodness we developed x-rays, but you're talking about localized pain, decreased function, inability to use or weight bear. They don't want to move it. Kids will often really push you away. And again, you may or may not have a deformity. Anytime you suspect a fracture, you need to immobilize it. You need to decrease its movement. You're not only saving the patient, decreasing pain, but you could be preserving function as well. So immobilize if you suspect a fracture. Now, we talk about fracture healing. This is, we want those bones to come together and heal. Well, first off, they usually start with a hematoma. So you're always assessing circulation. You're assessing for the risk of compartment syndrome, if that hematoma gets too big in that confined area. Then granulation tissue starts to form. Callus formation is really the beginning. You get, or not the beginning, but that's when you start seeing some really nice healing. And, you know, on x-ray, you can see the callus forming. It can be really quite large compared to the bone ends that it's healing around. Ossification is where the calcium comes in and the hardening of that callus formation. Consolidation, and ultimately remodeling. And so those are the stages of the healing process for bone fractures. And again, this is that in a picture: hematoma, granulation tissue, callus formation, ossification, and then healing and remodeling. What impacts a fracture's healing process is, well, the site of the fracture and how displaced it is. What's the blood supply to that area like? Is it been immobilized effectively and protected from damaging other tissues in the area? Are they using internal fixation devices, which we'll talk about? What's the patient's nutrition status? What's the risk for infection? How old is the patient? Do they smoke? These are a lot of the same concerns we have about the healing of any injury or any infection. You want to maximize their chance for healing. And so what are we, one of the goals is early on is to make sure we attain anatomic realignment. This is called reducing the fracture. Not exactly sure where some of this phraseology came from, but if you have a misaligned or a displaced fracture, you're not going to get optimal healing while it's displaced. Getting it realigned is important. And it's not necessarily just pure brute strength that allows for realignment. Oftentimes it is, I'm not going to say as simple as physics and working the angles. Sometimes it's muscle relaxers that allows the bone to be realigned. But again, and I believe we talked about this at other points in time, on x-ray, what an orthopod considers, and I know I've said almost these exact words to y'all before, but there's the x-ray, it's clearly displaced. They'll go about the realignment, and then they'll post the new x-rays, and everybody will stand around. God, you did a beautiful job. That looks awesome. And yes, I see the difference, but to me, the bone still looks like that, but they're all impressed with the way they did it. And I guess that's just, comes from working in orthopedics for a longer period of time. Once something has been reduced, though, let's immobilize it so that it stays in alignment and we protect from over movement. That is really, really important. And that's what we use slings and casts and those other things for. Braces, thank you. A closed reduction is done, I'm going to say at the bedside, again, non-surgical, a little bit of pulling, a little bit of traction, a little bit of muscle relaxants with analgesia. And amnesiacs can be all that you need and can be highly effective. An open reduction is a surgical realignment, going to the OR, opening the limb, opening the area, reducing it, trying to align it. And it often requires internal fixation, screws or pins or some other appliance to help maintain that alignment. Needless to say, with an open reduction, there's increased risk for infection. So we're going to be monitoring for those issues as well. One of the advantages of internal fixation is it often allows for earlier ambulation, which has its benefits. And the other thing we need to worry about or take note of, whether it's an open reduction or a closed reduction, is while we may immobilize that fracture joint and area, you want to make sure range of motion is maintained on all the other joints as much as possible. So don't let a patient become debilitated just with the hope of protecting the one injury. Traction can decrease or prevent pain. It can help manage muscle spasms. It is one of our ways that we immobilize different joints. And it can also help reduce dislocations or treat a pathological joint condition. What you're usually, traction is just using force to pull in opposite directions two types of tractions. There's both a skin traction and a skeletal traction. Skin traction tends to be short term. You use tapes or boots, splints that are applied to the skin. It's low traction weight, 5 to 10 pounds, and you have to be meticulous in your skin assessment and prevent breakdown. It is real clear that when a patient's in traction, whether it's skin or skeletal, range of motion and movement in the bed is very much decreased. So Buck's traction is an example of a skin traction. Here, this lower limb has been immobilized in this foam boot, and you see right here at the end, the strings are going to the traction. So it's effectively pulling probably the thigh, possibly something in the lower extremity there, but that 5 to 10 pound weight with the body being the counterweight is stretching and improving the alignment of that fracture. Skeletal traction is a longer term intervention. Usually a pin is inserted into the bone, and you can use, again, depending how much weight is used usually depends on the weight of the patient, or the counterweight, if you will. So they can use up to 45 pounds of weight in a skeletal traction. You've now created 2 holes into the skin and the bone. So again, significant risk for infection and all those hazards of immobility that we worry about. This is a picture of a skeletal traction. And so in this case, again, we've got our right lower extremity elevated. There's a pin inserted in this, probably this, damn, that's a hell of a setup there. So you've got both the leg being elevated here, and you've got it being pulled in from this weight. Those are the sandbags offering the weight on that end. This is a sandbag on this weight also. So in this case, the body is not being used as the counterweight, but there are sandbags being used as as the counterweights here. So maintaining the patient's position in bed becomes important. If the patient slips, you're not only changing the angles, but you're changing the effects of these weights. So know where the patient's supposed to be in bed when they consider it perfect alignment. You want it to be continuous, and obviously we don't want the weights hanging on the floor. That is somehow not useful in the plan. So skin traction is usually contraindicated in the elderly because of their fragile skin. Skeletal traction, we have trouble with folks with osteoporosis, folks who are immunocompromised, people with either respiratory or circulatory problems because their motion is sorely limited, people with cardiovascular diseases. And we usually don't use skin or skeletal traction for folks with claustrophobia, those who are pregnant, or those who have rheumatoid arthritis. A cast is another way to immobilize a fracture. Cast obviously is temporary. It should allow the patient to perform some of their activities of daily living. Nowadays, they're used in mostly some sort of silicone plastic material, but again, they come in many different formats. And the trick is to usually immobilize the joint above as well as the joint below the fracture to make sure the alignment is maintained. Again, the olden days plaster of Paris, maybe they're still using that. But what you do is the bones are aligned. A piece of knit cotton stockinette is placed over the arm. Padding is applied, big fluffy padding is applied. Then the silicone or the plaster is put into warm water, and then you wrap the limb in the plaster of Paris. You mold it just the way you want it to be, and it sets very quickly. And you need to let it cure probably for up to 3 days to ensure that it's well cured, dry, and is going to be able to support the work or the weight bearing. Weight bearing, even in simple fractures, is one of the things that needs to be determined by the clinician. There may be reasons that the patient should not be weight bearing for prolonged periods of time, whether it's casted or not. So you need to be clear about those instructions from the clinician. But if they are allowed to weight bear, you still need about 3 days to ensure that that cast is well cured. And casts need to be kept dry. If they get wet again, they're going to essentially dissolve and the support gets lost. Again, as I said, casts now are more lightweight, they're stronger. They say waterproof, so the cast might be waterproof, but when water gets in under the casting material up into the skin, there's increased risk of skin breakdown. And how many folks have had a cast in their lifetime, whether it be as young or old?
I just got my first one on at as like a practice for the pediatric specialty center I'm in for community.
Oh, no kidding.
So they put a cast on me on my foot. It was the weirdest feeling, but it was cool. I know how to cast people if I needed to.
Oh, well, that's excellent. And I assume they didn't leave it on for very long?
No, they let me walk around on it because it was a walking cast, and they sawed it off like 10 minutes after.
How about anybody wear a cast for a longer period of time?
I had a broken leg.
Does anybody, you want to talk about the smell when you took that cast off?
No, I would say it didn't smell that bad, but it was terribly itchy. So
How old were you, Eugene?
I was like my late 20s.
Okay, so you were probably more mature and you weren't a kid still playing with mud pies and in the sand lot and stuff. Let me tell you, taking off some of those casts from some of those kids, oh Lordy, what grows in there. But nonetheless, you know, you still want to try to keep them dry, whether they say they're waterproof or not. You're really not helping the skin, if anything else, by getting them overly wet. And again, you can have short arm casts, long arm casts. This one is done as a walking cast. You can see there's a support under the foot there. But it's pretty clear that mobility is going to be limited while that cast is on. The saws they have to cut off casts, once they hit air or some soft tissue, they automatically stop. So they're really very safe when you're cutting them off. You don't really damage tissue. The other thing you notice, and Eugene, you can speak to this, is the atrophy of the muscles when the cast comes off. You really do need to rework that area of the body again. It has been, you know, most casts are on for sort of a minimum of 4 to 6 weeks. And that's a surprisingly long time that can really alter the muscle strength of that limb. Would you agree with that?
That's true. After 2 months, so my leg was like, my ankle was like half of the calf, half of the other one. But it actually restored pretty fast, I would say.
Yeah, when you're healthy, you can restore it fast, but it's again something you need to work on.
And then my friends brought me right away the long metal ruler, the thin one.
To be able to scratch inside.
Yes.
Yeah.
Should be flexible and long, yeah.
Yeah.
Because that's
and we usually discourage that, because if you damage the skin, you don't always notice it or know it, and you can end up with a skin infection.
Right.
Again, warm, dark, moist place. Perfect. Environment for things we don't want growing on the skin. But to the person who has the fracture, the need to get something down there and just rub that skin is just huge. External fixation, I talked about earlier. This is not only can they do internal fixation with pins and screws and plates and rods and all sorts of stuff, but they may do external fixation also, pins and rods to help maintain alignment, keep different pieces in place, and to help apply traction. This is so these are all shots of external fixation devices they're using to keep different, it could be alignment, could be different pieces in place, quite significant. And again, think about all these different entry points for risks of infection and all. So pin care is really important. For you guys up on 7-7, have you seen any external fixation devices like this? Or maybe not?
Yes, and we also saw a cervical collar one from somebody who was a gunshot wound.
Oh.
Yeah, we see something like this almost every week, honestly.
Yeah, God love you. So what do you do for pin care, Nick, Kristen, Kevin?
I don't want to say not much, but it's a lot of just really, really delicate care around the site that's entering into the skin, monitoring for sites of inflammation or anything that would, throw us to an infection, looking for swelling, pretty common infection symptoms.
And do you use sterile water or sterile saline in the hospital to clean the pins?
I'm going to say sterile saline. I honestly haven't really seen them cleaned too much. A lot of that is done by the physicians, and we'll either miss it or we're just not there for long enough to see it cleaned, but I think saline.
Yeah, that's what I had always heard and what I always yearn. And again, you're not manipulating, you're really just sort of swiping around, looking, making sure there's no goobers accumulating or fluid coming out, whatever that's called, you know what I mean.
And we also,
oh, you're breaking up, Kristen. I'm sorry. If you want to pop that into chat, I'm sure it'll be helpful. Again, but you are looking at pin position, looking for loosening and signs of infection. And again, all of that needs to be taught to the patient as well, and or their family. This is internal fixation when we talk about pins and plates and screws and things like that. These are permanent. They're going to be left in there forever. So again, patients should certainly know that they're there and be aware that they have devices in them. When you're doing your assessment, one of the things you want to be aware of is the mechanism of injury. And again, in pediatrics, we want to know mechanism of injury for a couple of different reasons. Because we are assessing, does the mechanism match the extent of the injury? But also, are there any other, especially in a trauma situation, what other traumatic injuries might we anticipate due to the mechanism? Are there any known bone disorders, systemic diagnoses we should be aware of that's going to impact healing and things like that? Are there issues around immobility, osteopenia, or osteoporosis? What medications are patients on? And what are their history of surgery, other traumas, and other treatments they may be undergoing? We're always assessing their functional health patterns as folks get older, or women getting estrogen replacement therapies. Are they on calcium supplements? Is there already a loss of motion or weakness, either in an affected part or any other area of the body? Are they having muscle spasms now, pain, numbness, tingling, loss of sensation? Or as I like to call it, that CMS, CMS assessment. When we're assessing for pain, numbness, tingling, loss of sensation, what are we assessing for? What are our primary concerns there?
Circulation, motion, sensation.
There you go. So circulation, is there damage to the circulation in the area? Is there nerve damage to the area? And so there may or may not be bone damage, but we want to know about these other system assessments as well. Observe your patient. What do they look like? How are they letting you approach them? What other injuries do they have? Looking for signs and symptoms of hematomas and ecchymosis and things like that. Checking circulation and skin temperature. I can't say that enough. Looking at delayed capillary refill. Aligning a bone where there is circulatory damage is still not going to lead to a good outcome if we don't maximize circulation to the area. And this is particularly true when you're first assessing the patient for an injury, and particularly after an intervention. Once a limb has been aligned, once it's been casted, once it's been wrapped, you want to make sure you've preserved and or improved circulation, and that there's no new damage or new concerns, that no nerves have been caught and are going to suffer because of the alignment. So you do this on admission, and you're checking them consistently even after intervention. Again, if you've got deformities, if you've got loss of motion and function, again, those are all things that are notable. The classic hip fracture is a shortening and external rotation of the lower limb. And so you've got these older folks who come in, maybe they fell, maybe they tripped, maybe they did something, and they're laying there in the bed, and you've got a 1, 2, 3 inch shortening of one leg, and that foot is externally rotated. And you're thinking, you should be thinking to yourself, oh dear, I think we have a hip fracture here. There may be other stuff to consider as well, but that's one of those external sort of obvious injuries that should make you go, We talked about peripheral or vascular assessment. You're checking cap refill. You're talking about the color of the limb, the temperature, pulses, swelling. And again, swelling is particularly of concern because of the risk of compartment fracture. You've had an injury. We know there's going to be a certain amount of inflammation to the area. That's expected. On the other hand, when that inflammation whether it's just inflammation or a hematoma, starts impeding circulation below the area of the injury, that's a different, higher level problem that we need to be on guard for. And again, you don't want permanent nerve damage. You want to be aware of impaired nerve function, whether it's sensation, function, or pain. And you need to mitigate that, hopefully, as part of the treatment. So certainly impaired physical mobility, risk for peripheral neurovascular dysfunction, pain, and readiness for enhanced self-management are nursing diagnoses that can be applicable to these patients. And to the females in the group, again, I heard a couple of the guys say they had casts placed. Has any of the gals had lower limb casts and had to use crutches?
Yeah.
Yes.
Quite a few.
You want to talk about how hard it is to use crutches?
It was pretty dreadful. I had it in high school and in college. So high school, we only had one elevator in the whole high school. It's like 500 and something kids. It's about a quarter mile long. So anytime you change classes, it was a pain in the butt. But I mean, you kind of lived with it. And then college was even worse because you're crutching across campus to everything. Yeah. There's no shuttles on my campus, and I did not have an elevator in my building. I was on the 4th floor, and that was just a boatload of fun. Yeah. So don't recommend it unless you really have to.
Yeah, you know, and there's been a fair bit written in older stuff. I have to admit, I don't know if it's new, but you need a fair bit of upper strength to use crutches appropriately. Think back to lab last spring when you were learning how to use crutches. Again, you're really using your arms. You are not using your underarms. And so you need to make sure that your arms have the strength to carry through and not, especially when you're not weight bearing. This is not, often when you're using crutches, it's not a 4-point help walk, it's 3 points only. And it's exhausting on the upper body. And women have traditionally had a lot of issues with long-term crutch use. On some level, again, you don't want to look like the little old lady, but a walker can be a little bit easier to use for folks with limited upper body strength.
And it can get really painful for your armpits after a while. I know they get like additional padding on the crutches and stuff.
You see, Jack, I mean, that's exactly the point. That you should never be resting on the armpits.
Yeah. I mean, it's uncomfortable though, because not only, even if you're not resting, it rubs along your arms.
Oh, that's true. Yes.
So yeah. That gets really obnoxious.
Yeah. But you need to make sure that they're not resting on their armpits. Yeah. Because that just impedes circulation also in a whole different level.
Honestly, the best option is a scooter. If it's not a full cast, the little leg scooters are the best.
Yeah, where you kneel on it and zippity do around. I've heard that. Yes.
I had crutches for like 6 months for ACL reconstructive surgery.
Yeah.
And I had the leg cast from like my ankle to my upper thigh, and it would smell bad. But it had exchangeable pads that I could like wash and clean occasionally.
I had a knee injury where I had I had that same cast from the foot all the way up to the upper thigh. Oh Lord, that was probably the worst. I was only in it for 2 months, and that was it just was awful. It's no fun. All right, so we want to promote healing. We want to manage pain, and we want to have patients not become more debilitated while they're immobilized than necessary, and we want to maximize the rehabilitation over time. We want them to be safe. We don't want another fall related to whatever devices they're using to get around in. We want to make sure their environments are clear and that they can get done what they need to get done and or have help to get done what they need to do. And as I said, we don't want them to become more debilitated than necessary. So we want to encourage exercise, and we want to encourage full range of motion of all their other joints. And we want to maximize our calcium and vitamin D to promote good bone strength. You know, nowadays I love the idea of the orthopedic emergency departments where the offices, the private orthopods have opened their own urgent care centers. You get in, you get your x-rays, they're able to usually take care of you right then and there. And it has, I think from a patient perspective, has really helped a lot in terms of patient movement and patient satisfaction. Certainly not all injuries require hospitalization. Certainly not all injuries require invasive treatments. And so the best bet is to get them seen, get them diagnosed, get the proper immobilization on board, and get them home as quick as possible with appropriate follow-up. The importance of immobilization needs to be taught to our patients. How to use our assistive devices is really important. What activity limitations they have are really important, and to make sure we manage their pain. You guys, I'm just going to put you on mute for 1 minute. I need to talk to Abby for a sec. Hold on. Sorry about that. So pain medication, yep. All this patient teaching. Post-operatively, you know, we need to know what sort of anesthesia they had so that we can do proper respiratory assessments, monitor vital signs. And then from the point of the injury, again, those CMS assessments, watching out for bleeding, and making sure patients know how to manage their casts, their immobilizations, how to provide care for their sites and things like that are really important. We know the hazards of immobility in terms of constipation, potential for kidney stones, respiratory. We want to make sure they're using their incentive spirometers. And again, we understand that the limb might be immobilized, but they still need to keep moving. And that is really critical because we need to prevent all of these different things. And actually, when we're talking about long bone injuries, there are multiple other risks that come along with it that we'll talk about in a little bit. Again, managing pain, and again, it doesn't necessarily, it's going to be a combination of things. We're going to want to manage their pain. But I think the expectation of being completely pain-free might be overly ambitious. We need to use ice and elevation effectively. We need to use Tylenol and NSAIDs effectively. We don't necessarily have to go to all opioids to manage pain. So those are complications. Infection is an increased risk with any sort of open fracture or open fixation. Certainly an open fracture is of significant risk because this was an injury, this was a hole in the skin, a wound that was created out in the world in a non-aseptic environment. So the risk for infection of an open fracture is significant. And an open fracture needs to go to the OR whether they need to do fancy fixations or not. It needs to go to the OR so that it is cleaned out appropriately under anesthesia, and we're really mitigating the risk for infection there. So I think that's really important to know that while an open fracture may or may not be a more complicated fracture, the risk for infection is significant, needs to go to the OR to be cleaned if for no other reason. And while any sort of tissue infection is, we need to do our best to prevent it. A bone infection, what is a bone infection called?
Osteomyelitis.
Osteomyelitis, exactly. We are talking potential for long-term chronic infection when you're talking about osteo. So again, soft tissue, bad enough, but osteomyelitis takes it to a whole another level of complexity. So prevention is the key. And again, cleaning, surgical debridement, they may not close a wound immediately if they feel there's either going to be significant swelling or a need for more cleaning because of significant tissue injury. We want, use our suction setups appropriately. And again, what the surgeon chooses to use to help assist with drainage is up to them. It could be a hemovac, it could be a Jackson Pratt, it could be any number of different things, but that's incidental. We just need to monitor the suction, we need to monitor and document the amount, what it looks like, and empty it at appropriate intervals. Sometimes skin grafting is needed to close up the wound of a significant fracture if the open wound is so significant. And again, antibiotics as appropriate. Talked about compartment syndrome a couple of different places. This is where you've got that increased internal pressure. It can be either from, again, the inflammatory response, hematoma to the area, but what happens is so much pressure builds up in those areas that you're compromising neurovascular function of that area and below where that compartment syndrome is taking place also. That is an emergency situation. You've got to maintain blood flow and neurovascular function. And it could, again, so not only do you have the swelling, but sometimes the compartment gets smaller as well. But I think the the swelling in that area is more common. Again, ischemia, cell death, loss of function. So careful assessment, early recognition. Doesn't take that long before we start seeing ischemia. But yet it could be, once it starts, it could take days before it becomes a significant issue. But once it's significant enough, you can have long-term damage within 4 hours. We talk about the 6 P's: pain, pressure, paresthesia, pallor, paralysis, and pulselessness. Patient's going to complain of pain, it hurts. That swelling is part of that whole pain syndrome. They'll complain of not only pain, but pressure in that area. Paresthesia is the numbness and the tingling. Pallor as the circulation decreases, the area is going to become more pale. Paralysis over time because of the decreased nerve function, they're going to have increased problems moving it. And ultimately, you're going to lose your pulses below where that compression's taking place. So those are the 6 Ps. Our job is to recognize the problem and to call for help. Part of it is you can start by elevating it. And again, we talk about pain that's unrelieved by the drugs and seemingly out of proportion to the injury. That should be a concern. Assessing urine output and kidney function, again, depending where the compartment syndrome is taking place. You can have, we talked about compartment syndrome in burns. If you have a circumferential chest burn where it becomes so swollen that you're impacting cardiac output, respiratory function and all. So you're going to have decreased circulation from those areas. So look for your urine and your kidney, urine output and kidney functions. So why, I said you can, again, with pain, you can start with elevation, but if it doesn't relieve, why do you not want to use elevation above the heart or ice specifically with compartment syndrome? Same reason that you, with people with peripheral arterial disease, you're not going to elevate those limbs either. What does elevation do?
Promote blood return.
Promotes blood return, but in sort of in the opposite end, what does it make?
Lowers the blood supply.
Right, it makes it more difficult for arterial blood to get where it needs to go. So while normally we want to reduce swelling, and that's a worthy goal, at this point in time, we need oxygenated blood to get to the farthest point. And elevating and ice is not helping that. We loosen bandages. We can split the casts, reduce traction weight. And the ultimate surgical intervention is a fasciotomy, where they cut through the soft tissue to allow it to expand even further. The ice and the elevation is ours to control. Loosening a bandage may be ours to control. The other two, this is why we're raising the alarm and calling for our licensed providers. Those with prescriptive authority, because these are interventions we can't take unto ourselves. This is a picture of a person who had a relatively simple fasciotomy. It was one slice to open the area. They're going to slowly close up this wound over time as the swelling reduces. This is another picture. This one, obviously the fracture was externally fixated, but required another fasciotomy to allow it to swell to maintain circulation. I'm not really going to go through VTE because you guys know about the risks of DVT and thromboembolisms. What we haven't talked about, though, are fat embolisms before. Is anybody a fan of the book A Separate Piece?
I've read it.
Do you remember what happened, Jonathan, in that book?
Yeah, one of the characters broke his leg, and then like towards the end he had I think a fat embolism and died.
Right. So, you know, that's exactly right. And the other character believes he jostled the limb that caused his friend to fall. She said, I can't remember their names now. But anyhow, yeah, so long bone fractures. So within bones are fat globules. They're in sort of all tissues. People like me can't get rid of them, God knows. When you fracture long bones and the pelvis, your risk of releasing these fat globules into the circulation increases, and it becomes a fat embolism. And just like a blood clot, just like an ear embolism, now you have this fat embolism traveling around, and if it gets stuck, it's going to prevent circulation, which is going to have all the same complications of a blood clot, an ear embolism, or something like that. So again, fat embolisms are things that you have to be assessing for, particularly with long bone and pelvic fractures. Again, whether the mechanical theory that fat's released from the bone or there's a hormone change that stimulates release of fatty acids, I believe both theories are in play. I tend to remember the mechanical theory more. But again, usually happens within 24 to 48 hours after an injury. We worry about all those signs and symptoms of a DVT or a pulmonary embolism. And you might see petechiae of the upper body, the chest, the axilla, the mouth membranes, the conjunctiva. So again, that's the sort of assessments that you're doing on these patients. Looking for petechiae, respiratory assessments. And again, this is a serious complication. Things tend to go bad quickly, like with pulmonary embolisms and other things. Patients will quite suddenly increase anxiety. They're a little difficult to get comfortable, and they have this sense of impending doom. They'll tell you they feel like something's wrong. And so again, they might start off a little pale and they go to cyanotic quite quickly. So again, rapid response, call for help, early rescue is really important. They may do studies for blood, urine, or fat cells in the blood, urine, or sputum. Arterial blood gas, you're looking for a low PaO2. On EKG, you may see ST segment changes. And a chest X-ray is going to look like, really significant, potentially interstitial pneumonitis. That's usually what's called a whiteout on chest X-ray. Again, you guys on 7-7, have you had any experiences with fat embolism? I don't mean to make it sound like it's a common occurrence, but it's certainly something that you need to be aware of with those types of fractures. Doesn't sound like it. Okay. So again, prevention is a much better option. And immobilization of the bone is key to that. And then in terms of management, it's symptom-related support. But again, another reason why immobilization of the fracture is so important. Turning, coughing, and deep breathing to the best of the patient's ability, using your incentive spirometer, maintaining that immobilization. That's what we mean by minimizing patient movement. We're not saying that they, don't do range of motion on other limbs, but that affected limb needs to remain immobilized. And again, oxygen intubation, and ultimately mechanical ventilation if necessary. All right, so fracture management requires astute attention to infection control practices. Which nursing assessment is paramount in determining if wound or bone sepsis is developing? Well, I would, certainly meticulous wound care is about prevention. Maintenance of fracture management, again, is about prevention. It's going to be between the restlessness and the vital signs. And what do we know usually goes first?
Vital signs.
Yeah, I probably would have said restlessness, but I think that could be a bit of a me not remembering right. It's the answer in the, let's see if we have an answer. Vital signs, you are correct. Thank you. All right. A comminuted fracture may be classified as an injury in which bone protrudes through the skin, tendons and ligaments are disrupted, the ends of bones are impacted into one another, or a bone is fractured into two or more fragments.
D.
You said D, as in dog, two or more fragments, right?
Yes.
Very good. Okay, Andrew has an open book fracture of the pelvis after being pinned under his tractor. What life-threatening situation is causing his unstable BP?
D as in dog.
Retroperitoneal hemorrhage. So an open book fracture is where the fracture is forced back like the pelvis is opening a book, and you always worry about retroperitoneal hemorrhage in those cases. You can, there's really not an external, I shouldn't say that, I don't know that, but we're not talking about mass trousers here. We can talk about that some other point in time. You can get some compartment syndrome there, but initially you worry about the retroperitoneal hemorrhage for sure. All right. Okay, so stop share. So why don't you guys take 10 minutes, everybody come back at 12:05, and do you want to do TB, tuberculosis, or HIV next? Vote in the chat, let me know, and I'll see you back here at 12:05, okay? Thanks.
Thank you, Joanne.
Thank you. HIV. HIV.
Okay. I want to. Well, okay, everybody, welcome back. Seems like the vote went for HIV and AIDS. So let's get started. Now, again, James, Eugene, I think we're really the only three who can remember 1980, 81, 82, 83. Clear enough to understand what a big deal this was from sort of a sociologic study, let alone epidemiological. It was really unprecedented. and the fact that HIV and AIDS has become a chronic disease and is not viewed as a death sentence is just remarkable. Because I'll tell you, in the early days, it was nothing but a death sentence and a not pretty, but very ugly, painful death it was. There are more than 1 million people living in the United States now with HIV and almost 33 million people worldwide. And there are still new infections every day. And yet almost 2 million people a year are dying with AIDS. The stages of the disease, first off is the primary infection. And again, this can be a combination of asymptomatic or a flu-like syndrome. But this is when and it's a retrovirus actually, but the virus starts replicating in the body. And it could be a long period of time, while a patient is asymptomatic. Again, the initial infection may be characterized by like flu-like syndrome, but then in many cases, if not most, the patient is asymptomatic and is unaware of their infected state and unaware that they can pass on the virus. Viral replication during this asymptomatic period is less than it is in the initial primary infection, but still continues for some period of time. When do you start seeing symptoms of HIV infection? Well, it's when the CD4 T cells falls below a certain level. The HIV itself, for the most part, is not the problem on some level. That's not where you see symptoms. It's the fact that the patient can no longer fight off infections. And once the patient reaches a CD4 level lower than 200 cells per millimeters cubed, that's when you say the patient has AIDS. So it's a process. It's a continuum, if you will. There are, in fact, 2 different types of HIV infections, HIV-1 and HIV-2. HIV-1 is the overwhelming type of infection throughout the world. It's over 90% of all cases. HIV-2 has a smaller number of cases worldwide, has a very different and slower progression, and is seen more commonly in West Africa. Why has getting a vaccine been such a problem to combat HIV? Is because this retrovirus mutates very fast, very often. It's made vaccine development very problematic. Where does the virus sit? It sits in people's body fluids. So you're concerned about exposure to blood and body fluids from whatever source that may be. It can be in the days before blood was being tested, many folks received it as a function of a blood transfusion or a blood product transfusion. It can come through transplantation of tissues or organs. Again, people are tested extensively for that now. And infected semen, as we know, was one of the main sources of infection in the early and frankly continuing days. And it was very much, although this was very controversial, and there are a couple of different media things that you can watch if you want to get a sense of the early days. If anybody's either read Randy Schultz's book in the Band Played On, or if you've seen the play The Normal Heart, which is a story of a gentleman that just died this past summer, spring. He founded ACT UP. It'll come to me. Gay Men's Health Crisis. Larry. What's Larry's last name? Oh my God, I know it like I know my own. Anyhow, it'll come to me. Anyhow, once we got a sense that this was in fact an infection of some sort and that behaviors played a role in it, well, we understood that certain behavior changes could help prevent transferring the infection. And why do we say drugs and alcohol? Well, drugs and alcohol, mind-altering substances like that, make people engage in riskier behaviors that they might not do when they were sober, if you will. Drugs also carried, particularly IV drug users, carried the risk of transferring the virus through sharing of needles. People with multiple partners not using condoms and other safe sex practices. Just like we know with HPV virus, the risk of infection is higher with people with multiple partners. Engaging in sex with people with sores in the genital area and people who are oral receptive or anal receptive in sexual practices have a higher risk of disease transmission. So those are some of the behaviors we want to try to mitigate and practice safer behaviors. We've also learned that post-exposure prophylaxis can make a big difference in mitigating the transfer of the virus, even with exposure. So we know accidental exposure of healthcare and public safety workers. What did you learn about if you got a needle stick from a contaminated or a used needle? What's the first thing you should do?
Wash your hands.
Give me a little bit more. It's even a little bit more than just
running water and soap.
You want to flood that area. You want to, just like you're milking that area for a finger stick, you want to clean out that area as best as possible. And then head on over to your employee health clinic, urgent care center, emergency department, and they'll discuss with you the advantages and disadvantages of taking medications for a period of time. We want everyone to practice safer sex. We don't want unprotected anal or vaginal intercourse unless all participants have been tested and known to be positive and are monogamous. We don't want to be oral receptive in intercourse with ejaculation. We don't want to share needles. We don't want to share personal equipment like razors with people who have the infection. We use prophylaxis with people who have been raped and are unaware of what the potential, well, we know the potential risks, but we don't know the incidence of that risks. And again, our education is all geared towards stopping and mitigating high-risk behaviors. Seroconversion occurs typically 1 to 3 months after exposure. That's when those HIV antibodies are first detectable. So we used to say back in the day, and it's not tremendously different now, what does a negative HIV test tell you?
That you just don't have the antibodies for it.
That's exactly right, Kevin. Which almost kind of tells you nothing in terms of if you're making a decision whether to engage in a certain behavior with an individual. You need, 3 months of negative tests. You need monogamy. You need avoidance of high-risk behaviors before you start going down that path. Because again, takes up to 3 months to seroconvert. Those are some pretty awful dice to risk, if you will. So again, the HIV infection itself is going to essentially destroy the body's immune system. It impacts the T4 lymphocytes, macrophages, B cells. It also affects the central nervous system because the infected macrophages produce these neurotoxins that impact cognitive function. And as your CD4 count decreases, your body becomes more susceptible to infections. We call them opportunistic infections because people with intact immune systems don't get a lot of these infections. They're really only seen in folks with altered, impaired, severely damaged immune system. And, even in the state, not even, but, as legislation progressed, you need a permission, informed consent to do an HIV test on patients. Once we got testing, again, you need to understand that that didn't come around for the first 3 to 4 years of the pandemic. So we were flying blind, as they say. And so for patients who were refusing HIV tests for whatever reasons, you don't need the same informed consent for a CD4 count. And a low CD4 count, what is at the time in people who engaged in high-risk behaviors, was seen as tantamount to a positive HIV test. The ethics of that practice can be debated. Can't say we all felt particularly good about it, but on the other hand, it allowed us to progress with some knowledge of what was going on and what the potential was for these patients. So another thing we need to talk about in terms of HIV is viral load. How, we can now actually detect the viral load. I don't remember when being able to detect the virus itself became possible, but again, at first we were really just going by presence of antibodies and CD4 counts. Now we can actually detect how much virus is circulating in an individual. And this is the path, this blue line of what the viral load sort of looks like. Again, your exposure would be here at ground zero, and then anywhere from 2 to 4 weeks, that viral load shoots up and stays quite high. So this is that initial infection period. That slows down, and then there could be a latency period at some point in time. And again, as AIDS and the patient has overt AIDS, the viral load increases again. But what happens almost consistently over that time is the CD4 count. It plateaus at some point in time, but is almost always on a downward trajectory. Again, what is a CD4 cell or a T cell? Well, that is the type of white blood cell that protects the bodies from infections. They are the ones that activate the body's immune system. They're the ones out there detecting the foreign visitors like viruses or bacteria. And what happens is HIV destroys CD4 cells within the immune system. And then even worse, the HIV uses CD4 cells to make copies of itself and spread throughout the body. This is why HIV is termed a retrovirus. It actually copies the opposite of itself within these cells. Normal CD4 count is from 500 to 1200. Fewer than 200 cells qualifies as a diagnosis of AIDS. And ART, or active retroviral therapy, is the chemotherapy, the drugs used to combat HIV infection. Everyone who's been detected with HIV or is on prophylaxis should be on some form of ART therapy. And it's particularly urgent to start it when CD4 counts are falling. Sorry. Again, that initial period often goes unrecognized, that primary infection. As I said, it's a mono-like or a flu-like symptoms. And then HIV has a burst of activity with that increased viral load. Think of that chart a couple slides ago. Starting antiretroviral therapy treatment as soon as possible can actually save the immune system at this time. The latency period, again, is that period where there's no clinical manifestations, but the CD4 count starts to drop. It may plateau, but it's going to start to drop. Again, highly active retroviral therapy becomes really important. You want to maintain your CD4 count at all costs to a certain extent. When the viral load increases and the CD4 count lowers, you're going to have upper respiratory tract infections, fatigue, you're going to see candidiasis, lymphadenopathy. So these are some of those symptoms that you look for folks who are coming out of the latency phase. Night sweats is another big one. And as that CD4 count continues to drop, again, these are some of the things that we saw early in the early phase of HIV pandemic. Kaposi sarcoma, PCP, pneumocystic pneumonia, different brain infections, GI infections, CMV infection, thrush, herpes, tuberculosis, cancers that I had never heard of before, let alone seen before. And all of that's happening when the CD4 count gets below 200. Again, to qualify for AIDS, you needed a CD4 count of less than 200 and an AIDS-defining illness. AIDS-defining illness were those opportunistic infections that you just didn't see with people who had an intact immune system. And if you're not taking antiretroviral therapy, you're looking at death within 2 to 3 years. And frankly, that 2 to 3 years is only because we've gotten a lot better at treating opportunistic infections, not because AIDS has slowed down in any way, shape, or form. Again, someone who is HIV positive, has HIV, is those early days of the infection. You're classified as having AIDS when you have a CD4 count below 200 or you have HIV-related infections or cancers, opportunistic infections or cancers. And these opportunistic infections, as I said, pneumocystis pneumonia, tuberculosis, again, without other, anybody can get TB, but it's the TB without the other classic risk factors. Chronic diarrhea, esophageal candidiasis. Now again, many of you have seen babies who have thrush. You've seen babies who have the white in their mouth. You have not seen anything like full-blown esophageal candidiasis with people with HIV. These are people whose mouths are full of this white foamy infection. Every time they cough, they cannot eat because of the pain, the burning down their esophagus. It's unbelievable. Wasting syndrome. These folks, it's a combination of they can't eat because of the thrush and the diarrhea and the vomiting, but also they're literally, just calories are not making a difference to them. Kaposi's sarcoma is a cancer, again, was only seen with folks who were severely immunocompromised on severe chemotherapy. And it usually starts with they start small, but they grow into large purple lesions. And you can see the lesions on the skin, but these lesions also form internally. So that they can become obstructive in the GI tract and really alter organ function. Lymphomas, and then HIV encephalopathy. We've talked a lot about liver encephalopathy. And so this is encephalopathy caused by the HIV infection itself, and not particularly well understood as to why it happens, but the cognitive decline, the confusion, the agitation are significant. Cytomegalovirus virus, CMV virus, was very common, impacting the eyesight of folks. We had folks on top of everything else were going blind from CMV. And CMV doesn't only impact the retinas, but can in fact impact other areas like the GI tract as well. Depression, needless to say, other skin conditions, gynecology, they're much more prone to HPV virus, much more prone to GYN cancers, and immune reconstitution, inflammatory syndromes, which again is a whole nother separate manifestation. So again, I already talked about Kaposi's, where you find them. Again, they can be mitigated with radiation and certain chemotherapies, cryotherapy, but this is essentially a terminal disease for many folks. And this is what the early lesions look like, but they can get much bigger, much more significant. And again, these are the ones you see externally, but the fact that they form inside is really what is complicating the matter. Antiretroviral therapy slows disease progression. This is why these antiretroviral drugs are why AIDS has become a chronic disease. Yes, it's complex. Yes, they have side effects. It says it doesn't work for everyone. That's true. But as more drugs come to market, more patients are doing well with ART therapy. And it can be expensive. That, again, newer drugs are very expensive. Again, you need to understand that ART wasn't even available in clinical trials until probably earliest was 1990, I think, is when it went to stage 3 trials. And then you would go to these HIV conferences, and there were alarms going off, it seemed like every minute, because the early therapies were every 4 hours. The pills were, you know what those potassium replacement pills, what the size of those are? Folks were taking anywhere from 4 to 12 of those every 4 hours around the clock. Frankly, you knew who was positive in the audience because their alarm would go off every 4 hours. And it's come down to, some of these drugs are once, twice a day. They're combining therapies into one pill. It's come so far from the 1990s. It's amazing. But those early days were unbelievable. And again, these people were so nauseous and so sick. The last thing they wanted to do was take their, however many pills it was. It could take you half an hour to get 4 to 6 of them down, but it's what these patients needed. Again, antiretroviral therapy, the sooner you start, the better off you are. That's for sure. But the problem is your patient needs to be on board. Your patient needs to be compliant. What's the reason we don't have a vaccine for HIV yet?
You said it mutates very quickly.
It does. And what do we know happens to basic bacteria when you start and stop antibiotics or you don't fully treat it? What happens to those bacteria?
Do you create superbugs?
You create superbugs. Well, I'll tell you, the same thing happens with art therapy. If they're not compliant, the chances of the virus they have mutating and becoming more difficult to treat rises exponentially. So if you're going to start ART, you need to be consistent and you need to adhere to the plan. It is like a really big deal. And I will say, some of these folks who are at high risk for HIV or have HIV are not living a life that is consistent with consistency and structure and compliance, if you know what I mean. And again, you've heard me say what the population I worked with really was primarily IV drug users and pretty much sex workers. We had our occasional folks, and you didn't. I shouldn't say that, but everybody's story was heartbreaking. Did I tell you have I ever told the story about the 4 guys who got together every couple of years? They had served in Vietnam together. This is such a classic story of Vietnam veterans on some level. So the 4 of them were over in Vietnam, and I gather that many people, when they were in Vietnam, made use of the readily available heroin and other opioids that were quite commonplace over that. They lived through Vietnam. They all came home. They were from different parts of the country. One guy went on to college, became a very well-known lawyer, very successful. Another guy went on to become a police officer. Another guy did very poorly and never really recovered from his Vietnam experience and continued to use IV drugs throughout his life. And another guy was a businessman with a family and the whole bit. And every couple of years, they would have a reunion and they would try to help their friend who was not doing well. And they would come together and, sometimes for old time's sake, sometimes just the way guys have a beer together, people have a beer together, they would do a little H, score a little heroin, and they would share needles. And this went on for years and years. And all 4 of them ended up becoming HIV positive and progressing to AIDS. And they, 2 of them were in Connecticut. All 4 of them chose to move to the New Haven area, and we treated all 4 of them on our inpatient unit at various and sundry different points in time. And at different points in time, all 4 of them would be inpatient at the same time, and all 4 of them died on our unit at different points in time. It was a different time. It was really difficult. But again, it's different now. They have therapies that can make a difference. Again, you guys don't remember, but James, you remember. What was it like the day you hear Magic Johnson was HIV positive? James might not be on, and I'm not sure whether Eugene was in the country at that point in time.
I remember that.
I remember Freddie Mercury.
Yeah.
I remember Freddie Mercury too. That was huge.
But yeah, but you know,
as a Live Aid.
Freddie didn't announce until 4 days before his death.
Yeah, or Rock Hudson either.
Rock Hudson didn't come out until after he was dead. Magic Johnson, at the pinnacle of his career, had a press conference and announced he was retiring from basketball because he was HIV positive. This would be like, I'm trying.
I want to say early 90s.
Yeah, 91.
I think I was in junior high. Yeah, that's what I thought.
Motion stopped on my unit. And this was like, where were you when Kennedy died? If you were working with this population, where were you when you heard John Lennon was killed? Where were you when you heard Magic Johnson was HIV positive? But here we are, 2020, and to say Magic Johnson is thriving is an understatement. Now, I'm relatively certain he had the resources to get the best of everything. And not only did he have the financial resources, but he had the cognitive wherewithal to follow directions and to do what was recommended. And that's, again, an important key to retroviral therapy.
And now Freddie Mercury would have been alive.
I agree with you. But again, the difference of, the difference of homosexuality in different communities. And, I forget where his family was from. He had
Persia, they were Zoroastrian, weren't they?
He had it was an interesting background, but it certainly, wasn't white Anglo-Saxon.
Zanzibar, sorry.
Zanzibar, thank you. Plus he was in rock and roll. If he was going to come out and said he shared needles, that might have been one thing. Not saying that was a badge of honor, but it's, again, being gay has taken on a very different perspective these days also. The cultural evolution from that perspective cannot, we can talk about that as well in terms of accepting who you are and being public with stuff like that. Rock Hudson's entire career was premised on the fact that he attracted women. Again, you just can't understand. It's different these days. So again, I talked about adherence and how important it is that the patients be able to adhere to this therapeutic regime, because the risk of mutation and the risk of severe problems is certainly important. The dosing schedules have gotten somewhat easier, but again, you may have individual patients who still require a complex dosing regime. There are definitely side effects, and some of them quite severe, and some of them are easier to tolerate than others. The ability to take other therapeutic drugs, let alone recreational drugs, is a separate issue. The cost factor and access to care are really important factors here also. This is a picture of someone with HIV wasting syndrome. Again, it's not particularly different than other wasting syndromes, but again, these folks are so fragile. They don't have a desire to eat. Even when they do eat, the calories don't seem to make a difference. And the chronic diarrhea, the anorexia are significant. But that's one of the things that antiretroviral therapy can really help combat and keep them healthier. Antiretroviral agents come under a couple of different categories. I'm going to assume you spoke to these in your pharmacology class. I don't really, you won't be tested on these. This is more of a FYI sort of thing. Treating the opportunistic infections. Well, not only do we treat these, we want to prevent them nowadays. So PCP, oh dear Lord, in the olden days, we had PCP clinics, and to prevent it, they were given aerosolized pentamidine. So you had folks sitting in the hallway with their masks, getting their treatments. You walked through wearing a mask because it smelled so bad. And now folks usually get a by mouth, whether it's a Bactrim, usually a Septra if they tolerate this antibiotic. But again, it's more, we know that it's easier to prevent nowadays. MAC complex, Mycobacterium avium complex, MAC, is treated with either Biaxin or Zithromax. You can either treat it, and it can also be used prophylactically at different doses. CMV, different antiviral agents, diarrhea. You need to really stay ahead of diarrhea. Keep them eating, keep them hydrated, and really try to prevent it as much as possible. And KS, again, no one treatment works much better than the others. So KS is still an ongoing problem. Part of the problem with some of these opportunistic infections is they progress so much faster in people with HIV than other folks. Lymphomas, depression is a big issue, malnutrition. And so we're always looking for ways to help these folks as best as possible. So again, patient education in terms of risk factors, patient education in terms of staying healthy, helping folks stay as healthy as possible, watching their hydration status, their nutrition status, maintaining skin integrity. And I've said this before to you guys, I am absolutely certain my father did not have any idea that when he was paying for my college education, that I would be out there teaching people how to clean their illicit drug use works so they can use it again and not get infected. But that's what you found yourself doing, even in New Haven, which was had a very active needle exchange program, and handing out bleach kits so that they could clean their needles in between using them. Maintaining skin integrity, bowel patterns, preventing infection, improving activity tolerance, maintaining thought processes, promoting airway patency are all really important with patients with AIDS, managing pain, discomfort, coping with grief, coping with patients' sense of isolation. The length of stay on my unit when I was nurse manager was over 400 days. At that time, there were no facilities in the state of Connecticut besides acute care hospitals who would accept known HIV positive patients. So there was no other place to go for antibiotics. There was no other place to go for rehabilitation. Many of these folks were homeless, and given the medications they needed, as we said, there's really no place to plug in your IV pump on the New Haven Green. So we got to know these patients very well. And the sense of isolation was significant. It was shameful. It was people would actively spurn you and cross the street to avoid you. Again, now that it's become more of a chronic disease, it's not as much on the front page of the newspaper, but I bet you in the general suburban population, someone who is known HIV would probably still get a similar response. I'm not sure everyone understands how far things have come. And with that being said, you still want to prevent infection. Just because it's become a chronic disease does not mean you want to have that label in any way, shape, or form. But preventative measures, there are multiple, this is old. I meant to change the slide out, I'm sorry. There are multiple preventive drugs now. They're all in the ART family one way or another, but it's all about PrEP, pre-exposure prophylaxis. And so you want to be able to, for folks who do have high risks, taking daily prophylaxis has become a standard of care nowadays. So following statement, true or false? An individual stage of HIV infection can be determined primarily by the results of viral load testing.
False.
That's false nowadays. That's right. HIV staging is based on symptoms and CD4 levels. Viral load certainly makes a difference as to what your risk for opportunistic infections may be, but that's no longer definitive. Is it necessary for the nurse to counsel the patient with AIDS to avoid individuals who have actual or suspected infections?
False.
Well, it's probably not as important, but we certainly want the patient to understand, it depends, I guess. This isn't as black as and white. It depends on what your CD4 count is. If you have an intact immune system, because you are true to your ART therapy, then it's important.
I misunderstood. So I understood that is it necessary for nurse to avoid individuals?
Right.
Yeah, so.
Yeah. So,
like, it's annoying.
but again, If you've got a compliant patient with intact CD4 count, that's less important. A patient with a recent diagnosis of HIV is scheduled to begin antiviral therapy. Sorry. What teaching point should the nurse emphasize when performing patient education? The need to avoid over-the-drug medications, the importance of taking medications exactly as prescribed, or the need to have viral load testing performed at least twice a week?
E.
E.
B as in boy.
Very good. And which of the following interventions should the nurse perform in an effort to decrease the patient's potential for isolation while being treated for AIDS? Arrange for the patient to be placed in a multi-bed hospital room, encourage the patient to express his or her feelings of isolation and loneliness, administer antidepressants as ordered.
B as in boy.
Beautiful, very good. All right, guys, it's 1 o'clock. You've been more than attentive. I appreciate it. I'm going to do a cheat sheet on the remaining lectures, but I'm going to encourage you to review them, please. I'm going to do a review for the final. When will be at a time of either mutual convenience, and it will be recorded, as you know. But more or less, we're going to meet again on Thursday. Well, actually, we won't meet again, but we will be in contact with each other Thursday morning, okay?
Yeah.
If not at the review. Any questions right now?
Oh.
You know where to find me, right? It was kind of nice not to start today with a quiz, wasn't it?
Yes.
Wish there were more days, I must say. But I will also say, not a lot of them left, at least in this portion of your journey, which is pretty good news. All right, guys, you know where to find me if you need me. Thank you for your attention. I really appreciate it. This lecture is always hard